Right. Okay. So let's discuss dengue. Right. Right. So, there are local students in this meeting, ERPM students in this meeting, different kinds of students are there. So we will discuss this in a way that it will be useful for everyone, right? And there are some pre-interns as well. So it will be useful for them as well, right? So how are we going to have the discussion today? It will be more of an interactive session, right? It's an interactive session, meaning time to time, I might ask a couple of questions. I'm not going to direct to any of you, right? So if you feel like answering, you can answer. If you don't know, you can just stay like you have an absensation, like this, right? Okay, so that's all good. Now when it comes to dengue, right? When it comes to dengue, I have already sent the note, isn't it? Yeah, I have sent the note as well, right? I have sent the note. Also, I have sent the question paper, right? So both of them were sent. We will fill the gaps while we are doing the discussion. Now, Buddha, when it comes to the exam, right, undergraduate exams, how is this topic tested, right? How is this topic tested? Dengue can come in different ways, isn't it? What are the ways how it can come in the exam, right? If you forget about the exam, right? When you pass the exam, what happens to you? You will be house officers, isn't it? You will be house officers. Once you become a house officer, like pediatric house officer, there will be this pediatrics ward, right? Pediatrics ward. If there are, I'm just giving a figure, say, if there are 100 patients, 100 pediatric patients, I will guarantee you there will be at least 20 dengue patients, right? At least 20 dengue patients. If you have already started to go to hospital, you already know that this is the truth, right? There are dengue cubicles as well, right? Dengue cubicles. So when you become a house officer, pediatric house officer, dengue is your day-to-day life, right? So we need to know dengue very well. Without knowing dengue, if you try to become a house officer, that's not going to work. Such a house officer will be a headache to the ward, right? Will be a headache to the ward, so that the examiners will make sure you don't pass final MBBS exam unless you are confident in dengue, right? So they will check it in different ways. In MCQs, there will be dengue questions, right? There will be MCQ, dengue MCQs, right? There will be dengue MCQs. And then what, Pudha? There will be dengue single best answer questions as well, right? Dengue single best answer questions as well. I don't know whether you have already seen one or two questions that I have posted in the WhatsApp groups, right? Unfortunately, most of you went wrong, right? Meaning dengue is not as simple as we think, right? As simple as we think. It could be straightforward, but it is not always the case, right? So dengue will come in MCQ paper. How else can dengue come in the exam, right? Dengue will come for local students in essay paper, right? In essay paper, they will evaluate a child with this and that suspected dengue. How are you going to approach? So that will be a very well-known essay question, right? And then for you both, whether you are doing foreign or like ERPM or local exams, KDU, local, or any KDU is also local exams, right? This will come as a short case, right? This will come as a short case, right? Also, this will come as a long case, right? This will come as a long case. How else could this come, right? How else could this come? Dengue can come as a MCQ. Dengue can come as a SBA. Dengue can come as a essay. Dengue can come as a short case. Dengue can come as a long case. How else? This will be one of the top 3 emergency scenario as well, right? Emergencies. So dengue can come as an emergency scenario in your emergency exam, right? For some exams, emergencies are separately tested. So you might get this as an emergency scenario as well, right? So during today's discussion, we will cover all those aspects, right? All those aspects, right? So Pudha, please keep the dengue note ready. So what I'm going to do is I will do a small scenario, go through the note. Another small scenario, go through the note. Another small scenario, go through the note. Then I will go to the guidelines. Once we are confident in guidelines, we will go through the questions, right? Questions, if you saw, there are like 30 or 35 questions. Initial questions are SBAs. The last couple of questions are true, false. When you cover them, that will cover A to Z dengue, right? A to Z dengue. Was that understood? Happy with the agenda? Ah, can this be in OSCE? Very good question, right? So you are talking about short case, long case. Can this be, okay, Aisha, can this be an OSCE? Yes, right. The new pattern of exam in ERPM is OSCE. Could it come as a OSCE? Yes, OSCE could, like, it's a short clinical scenario that they will give for you to sort out within 10 minutes. Right, within 10 minutes. So you might get a dengue child with an effusion. The command will be examine the respiratory system, right? Examine the respiratory system. So that will be one of your OSCEs. Or sometimes in that you might get a mini OSCE, right? What do you mean? They will say this child is 5 years old, weight is 30 kilos. Write the fluid prescription. Write the fluid prescription as a house officer, right? So you need to exactly write what the fluid prescription is going to be, right? So dengue, or sometimes you might get a full blood count report for you to interpret, right? Yes, thank you, Senil. So full blood count report for you to interpret. So dengue could be anything. Right. So how are we going to conduct the session today? Right. So there are a couple of pre-interns, right? Couple of pre-interns. Who is a pre-intern? It's an honorable post, right? Pre-intern is a student who has finished their exams, local or ERPM exams, now awaiting to become intern house officers, right? I will keep them in the discussion. So time to time, I might ask them to come forward and to have the discussion with us, right? So that's how it goes, right? Okay, now suppose, Huda, shall we write the scenario, right? We will write the scenario. This is the note that I'm going to share with you. This is the one. I don't think that you can see it yet. Right. Can you see this? Right. I have changed the first page, right? But rest of it is essentially the same. However, in some places, I have removed the areas for us to fill while we are discussing, right? So this is basically the paper or tute that we are going to discuss, right? So in that, at some place, right, somewhere here or wherever, if you can write a 5-year-old child, right, 5-year-old child coming with fever, right, fever for 2 days, right, 5-year-old child coming with fever for 2 days, right? Okay. Just give me a second. Right. 5-year-old child coming with fever for 2 days. Now, you are the house officer, right? You are the house officer. What are you going to do? How are you going to approach, right? How are you going to approach? That's the question, right? Okay. I will ask one of the pre-interns to come forward and see how you are going to manage. Pasidu, are you here?
Yes, sir. Yeah.
Pasidu, how do you appear in Zoom? How should I search you?
Yeah,
I
Prabhas.
found you.
Yeah.
I found you. I found you. Right. Okay. So Pasidu,
Yes.
you are the house officer, right? You are the house officer in base hospital, Balapitia.
Okay.
Right, Balapitia, right? So you have got a 5-year-old child, right? 5-year-old child. The mother comes to you and she is worried that this child, right? This child, say Tarindu is having fever for 2 days, right? You are the house officer. In the afternoon, you are seeing this child, right? And with the mother, right? What questions are you going to ask before we start? Let me introduce Pasidu. Pasidu is from Krusk State Medical University. He's the only one, right? Only one who completed all 7 subjects from Krusk State as a first timer this time. So Pasidu is waiting to go for internship because he's from southern area. His dream is to work as a house officer in Balapitia Hospital, right? I'm sure he's going to get it, right? So Pasidu, so Balapitia Hospital house officer, right? Pasidu, you are getting this 5-year-old child, right? What questions would you like to ask? You are suspecting possibly this is dengue. Yes.
So like first I have to differentiate whether this child is having dengue fever or hemorrhagic fever.
Mhm.
So I just have to check about the symptoms. So mainly I have to check the child got headache with retroorbital pain and nausea, vomiting, or any arthralgia, myalgia symptoms, and any flush appearance of the skin, and any rash, any diffuse or macular rash, and
Go
I
ahead.
can do with like tourniquets test, and I can go with I can tell to the patient to mother to take a blood report, full blood count, and if there is any leukopenia or platelet count, I want to check.
Right. So this is what you would do. Now, initially, in any child, like in Sri Lanka, any child presenting with fever, until proven otherwise, you assume that this could be dengue, right? This could be dengue. So when a child presents with fever, right? When a child presents with fever, you first have to, as Pasindu very correctly told, you have to take the history, right? What are the cardinal questions that you might ask, especially in your long case? You might ask, is there any headache? Retroorbital pain, right? Retroorbital pain behind the ඇස්යට කැක්කුම තියනවාද පුතා, right? ඇස්යට කැක්කුම තියනවාද, ඔළුව කැක්කුම තියනවාද ඔයාට, right? And then is there nausea, vomiting, right? Is there nausea, vomiting, right? And some children can get a initial rash, right? Not the recovery rash. Different rash is possible. So you might either examine or you might ask, was there any rash, right? So those are the questions that you will have to ask at the beginning, right? Now, Pasidu, suppose I am the father, right? I am telling, yes, doctor, my son is Tarindu. Tarindu is having headache, right? He is complaining of headache. He always prefers to sleep. He's having fever for 2 days, right? And when it comes to headache, he complains of eye pain, especially, right? He has got some eye pain. He is nauseated, right? He's having a bit of vomiting as well. He's not eating enough, right? And he has got a bit of tummy pain as well, right? Now, Pasidu, are you suspecting, right? Are you suspecting that this is dengue?
Yes, I'm suspecting.
Yes, you suspect, right? Now, Pasidu, we'll ask somebody else to do the examination part, but at this point, right? They are coming from Kosgoda, right? They are coming from Kosgoda, right? Slightly away from Balapitia. Now the mother is asking, or father is asking, doctor, what do you suspect? Now, Pasindu, what is your answer?
I'm suspecting dengue.
You
Dengue
suspect
fever.
dengue. Very correct.
Yes.
You are suspecting dengue fever, right? You are suspecting dengue fever. Now, father is asking, Dr. Pasindu, should my child be admitted? Should my child be admitted? Now, junior students, those are going for the exam. Now, what am I asking? Which of following are indications for hospital admission in dengue? Can it come as MCQ? Yes, right? Which of following are indication for hospital admission in dengue? Which of following are features of dengue? Right? When I'm discussing with Pasindu or some other pre-interns, you can put that into the viva language, right? You can put that into the viva language. Right, Pasindu, do you think that this child needs admission?
So I have to consider firstly about the full blood count, like platelet counts. If the platelet count is low, below 150, I should admit with the HCT count, and I have to check about the warning signs, like because this child having nausea, vomiting, like any bleeding, mucosal bleeding, or there is no any urine output within 6 hours, and like severe abdominal pain, like with cold extremities. And I have to check the patient condition, whether this child is an infant or like obese, or the patient is with any comorbidities like any renal failure or hemolytic diseases. And like the so you told, like he's any social circumstances, like he's away from too far from the hospital, so I should admit this child immediately.
Yes. So whether to admit or not, does every child with dengue need admission? No. Every child with dengue doesn't need admission. So what are the conditions where you might think admission is needed, right? Admission is needed. If the child is very young, like an infant, right? Infant, very obese children, because these children are at a high risk of getting bad, complicated dengue, right? Now, if you get MCQ, which of following patients should be admitted in suspected dengue? Infants, true. Obese patients, true, right? Any warning signs, as Pasindu told, right? Say nausea, vomiting. You think if you discharge this child, he's going to die with dehydration. So you will admit these children as well. And then if the social circumstances are not good, so you are telling, okay, give this much of fluids, mother is not able to understand, or she doesn't have enough social support, you admit, right? And then, of course, if the child is in circulatory instability, right? If the child is in shock, then you might need to definitely admit, right? So those kind of patients. And then Pasindu was mentioning about what? Investigation results. If you have done a full blood count, right? If you have done a full blood count, and if that full blood count shows a platelet count of less than 150,000, you need to admit, right? You need to admit, right? If there is a rising hematocrit, so you see there's something called hematocrit. If the hematocrit is high, of course, you need to admit. So those are the common occasions where you might think of admitting, right? You might think of admitting a child with dengue. Was that understood? Right. So what do we know so far, right? What do we know so far? Sorry, this is not the document I wanted to share. So if you go to the document, now while we are discussing, we will go through the document as well. You see how children with dengue will present high fever, like say 2 to 7 days of fever, headache and retroorbital pain. There could be nausea and vomiting, arthralgia, myalgia, flushing. They could have a rash, right? They could have a rash, right? So those are the common ways how they can present. Right. And then, as Pasindu was very correctly telling, if the child has got, right, if the child has got following signs, you need to admit. Why am I doing dengue extensively? Because this could come at any exam category. So we are not supposed to skip anything, no shortcuts for dengue, right? So we need to know everything. Right? We need to know everything. So persistent vomiting, right? If the child is lethargic, drowsy, right? If there is mucosal bleeding, right? If urine output is poor, severe abdominal pain, if the child has got cold extremities and shock, right? And then clinical features of leakage like pleural effusions, right? If the child is an infant, obese child, other comorbidities, liver failure, renal failure, right? Adverse social circumstances, social poor, no transportation. So that kind of patients from remote areas, irrespective of their platelet count, you might admit, right? You might admit. You don't say, okay, go home and come back tomorrow morning if they don't have a bus to come to hospital tomorrow morning, right? Was that understood, Buddha? So that's the kind of answer you need to give in Viva, right? As Pasindu very correctly answered, right? So this is how you need to give an elaborated answer when it comes to Viva. Then only they will understand. He is not only knowing the theory, he has some understanding about the social circumstance to work as a doctor in Sri Lanka, right? That is how you earn your pre-internship, right? That is how you earn your pre-internship. So take a Pasindu Gatta, right? Very, very well done, Pasindu. Right. So Pasindu, I will ask one of the other co-HOs to manage from this point. Now, Pasindu has decided to admit this child, right? Pasindu has decided to admit this child, and then some other doctor, right? Some other doctor will be there in the hospital, right? To look after this child, Harindu, after Pasindu has admitted, right? Now, Pasindu has decided to admit, right? So that is what Pasindu has done, right? Okay, thank you, Pasindu. Right, now we'll ask another co-HO to continue the management, right? Aisha, are you happy to continue?
Yes, sir.
Right. Okay, so Aisha, right? Aisha is our next pre-intern, right? Aisha, which hospital are you planning to go?
Nigambo Gampaha.
Nigambo Gampaha, right? Okay, Nigambo Gampaha, right? So yeah, you might get Nigambo. Last year or year before, in my when I was working in Nigambo Hospital as the Nigambo pediatrician, two house officers were foreign graduates. One was local graduate, right? So you might get Aisha. Aisha, you are from which university?
Nanjing Medical.
Nanjing, right? So Aisha is one of the top 10 rankers, and then she was, are you Nanjing first? Yeah,
no.
okay. All right, okay.
Ask
Now, Aisha, now Pasindu has decided to admit, right? Pasindu has decided to admit this child, right? Now, he has not examined, right? He has not examined. He had to attend to another emergency. You are now examining this child, right? What is the kind of child? This is Tarindu, 5 years, 2 days history of fever, coming with nausea and vomiting, retroorbital pain, right? Retroorbital pain. So now you are going to admit this. You are going to examine this child, all right? What will you examine?
So I will start with inspection, like how the child is appearing, whether the child is ill looking, or like if he's like comfortably like staying, and like, so if I don't find any like specific findings in inspection, I can go ahead for a palpation, because if the child has gone into the critical phase, which is leakage, the child might have like reduced chest expansions during palpation.
Right. Okay. If I stop at that point, Aisha, for a bit. Now, when a child presents with dengue, you took the history, right? And then you have started to examine the child, isn't it? You have started to examine the child. What can be the possible scenarios when it comes to dengue children? Dengue children could present to you in one of these 3 ways, right? Number 1, dengue fever only. Dengue fever only, right? They have fever, no other signs, right? The second feature is they could be in leakage. This is why dengue is such a VIP topic, right? we don't have like Zoom classes to talk about cough and cold, right? Cough and cold is caused by a virus. Why are we giving a special care to dengue? Dengue can cause this unique problem called leakage. Leakage. When the child is infected with dengue, their capillaries could be leaky, right? Please remember that very well, Pudha. But capillaries could be leaky. When capillaries are leaky, some dengue children not only will have fever, but there will be leakage of fluids out of the capillary. Leakage of fluids out of the capillary. Then what is the problem? When fluids are going out of the capillary means circulatory fluid amount will go down. Circulatory fluid amount will go down. This will cause circulatory insufficiency or shock, isn't it? Shock. This is the main reason why a dengue child could die. So we need to see if the child has got into dengue shock or dengue leakage, right? So general features are, as Ayesha very correctly told, child might look febrile, ill-looking, might be in pain, could be flushed, right? Could be flushed. If that is the only thing, Ayesha, what do you think as the diagnosis?
It's more likely to be dengue fever, sir.
Dengue fever only. Yes, dengue fever only, right? The next possibility is he might be leaking. He might be leaking. His capillaries might be already leaking, right? One way is to put a tiny microscope and see if the capillaries are leaking. Can you do that in practice? You can't. So you need to have an indirect evidence to say that the child is leaking, right? So Ayesha, if you are the house officer in Nigambo Hospital, how do you know if the child is leaking by clinical examination?
By clinical examination, so we can see like the child's blood pressure.
Okay. Before you go to the blood pressure, where do they leak fluids into?
Into the cavities in the body, sir.
Yes, pleura, isn't it? Pleura. So they might have features of what? Pleural effusions, isn't it? Ayesha, can you remember the features of pleural effusion?
Yes, sir. In the inspection, depending on the degree of the effusion, the patient might have difficulty in breathing. And if you like observe, there might be like a reduced chest expansion in the sideways. There is pleural effusion. And like generally, if the child is leaking, usually the child will be looking and
What will happen to the air entry if you auscultate?
air entry will be reduced, sir.
Reduced. If you percuss?
Dull.
Dull.
Stony dull.
Stony dull, right? Now, Buddha, especially in Viva, if you are asked, right, as Ayesha told, right, it depends on the severity. It depends on the severity. She also told, right, inspection, this is what you are going to see. Palpation, this is what you are going to see. Percussion, this is what you are going to see. Auscultation, this is what you are going to see, right? So if you examine a dengue child, you will see the child might be in breathing difficulty. Chest expansion will be reduced because there is fluid in the pleura, right? When fluids are leaking from the capillary, pleura will have fluid. That is called what? Pleural effusions, right? How do you know? Breathing difficulty, right? Reduced air entry. If you percuss the lung, because of fluid, the percussion note will be stony dull. If you check with the stethoscope, there will be reduced air entry. If those are there, Ayesha, right, you will definitely inform your seniors, isn't it? Registrar or whoever should be informed. If you examine the abdomen, right? If you examine the abdomen, what will you see?
In the abdomen, if the child has ascites, that is like leakage of fluid into the abdomen, the child might have like usually on inspection we won't find any like very prominent signs, because like even if ascites is there, they won't have a very big distended abdomen. So
that's a very important point, right? That's a very important point. Just because you know theory doesn't mean that you are going to pass Viva, right? Ascites, there will be fluid in the abdomen, But you need to know in dengue that fluid is not going to be very gross and distend the abdomen, right? There will be ascites, but abdominal distension is not going to be clinically evident, right? So if it is not clinically evident, Aisha, how are you going to find them?
So we can, the best way is like auscultation in the abdomen, because we can find the shifting dullness, and if the amount of fluid is
Auscultation
more,
or percussion?
sorry, percussion,
Percussion, right?
shifting dullness, we can like, that will be very prominent if the child has
Yes.
ascites.
So there will be, the child might have some shift in dullness. There could be percussion note will be dull, right? So if you see those, you know that the child is in where? Leakage. Pasindu has admitted this child. Now you have found that he is leaking. Was that understood? He is leaking. So that's how much you understood in this child. Was that understood? Yes. Right. Yes, Aisha. Shall we give the next set of evaluation to some other co-HO? Right? Yes. Yes, Aisha. So you will definitely get Nigambo Hospital or Gampaha Hospital. You have got a very high rank, first 10. So I don't think that there will be any problem when it comes to hospital selection. Right. Okay. I will ask someone else. Before I ask someone else, right? If we go back to the tute, right? If we go back to the tute, right? What did Aisha say? Right? Aisha was talking about features of leakage, right? So some children might have features of leakage, right? Early detection of critical phase. Api critical phase කියලා කියන්නේත් leakage එකටම තමයි, right? Leakage is also known as what? Critical phase, right? So when it comes to critical phase, right, what will happen? There will be pleural effusions, right? There will be pleural effusions. Fluid collections will be there in the chest. So that is called pleural effusion. Chest එකේ තියෙන්න පුළුවන්, right? Objective evidence of fluid leakage, right? Also in the abdomen, there will be what? Ascites, right? Abdomen, there will be ascites, right? There will be ascites in the abdomen. And then chest again, there will be pleural effusions, right? And the platelet count, if you check, right? If you check platelet count is at this point, usually it will be less than 100,000, right? Usually it will be less than 100,000 if you check the platelet count, right? Now, what is the situation? Now, what is the situation? Now, still we are assessing this child. We have not started the management of this child, right? What are we assessing? This child came with a history of fever for 2 days, arthralgia, myalgia, headache, retroorbital pain, vomiting, Pasindu admitted, right? Then Ayesha has decided, yes, now I am assessing. On the assessment, suppose you found that the child is leaking, right? Child is leaking, right? So are we happy about the features of leakage so far, Angelo? Yeah? Features of leakage? Yes, right? So think it as a scenario. Remember it as a story, right? Remember it as a story. Right, now our next, right, house officer has to decide, is it just leakage only, right? Or whether he has got some other problems, right? Yes, we'll ask from Senali. Senali, right, okay, Senali. Senali is our other pre-intern, right? Senali, which hospital are you planning to go?
Somewhere near Colombo, sir.
Somewhere near Colombo, wherever, right? Kohe hambunath kawanne, Colombo nang, right? Senali is from Tianjin University. She is one of the top 10 rankers, right? Yes, Senali. Now this child, right? Aisha was talking about the child and he was leaking, right? Leaking. When a child is leaking, if the leaking was not managed, what can happen to this child?
The child can go to the shock.
Go into the shock, right? Child will go into the shock. So this is what happens next, right? ඊළඟට වෙන්නේ child shock එකට යන එක තමයි, right? Now Senali, now Ayesha was telling that child probably is leaking, right? Ayesha examined, she found that the chest is having some pleural effusions, abdomen is dull percussion note, so she was worried, right? Could you please tell me, how do you assess to see if the child has gone into shock?
Yes, sir. I will check the hemodynamic stability of the patient. For that, I will check the pulse rate because the earliest sign of shock is tachycardia. So also I will check the pulse volume as well, sir. I
Okay.
will also check the blood pressure.
Yeah. Now, Senali gave you a SBA point. මොකක්ද SBA point? Earliest sign of shock. Earliest sign of shock is what? Tachycardia. Right? Tachycardia is the earliest sign of shock. Right? And then by the time child goes into shock, right, the pulse volume might be low, and there may be some like rapid pulse. That is what tachycardia means. Right? Okay. What else do you want to check?
The blood pressure and the pulse pressure.
Absolutely. You need to check the blood pressure. Now, suppose, Senali, this child's heart rate is 150. 5-year-old, 150. Is that high?
Yes, sir.
That is high, isn't it? Heart rate is high, right? And then pulse volume is low, right? And peripheries are okay. And then I'm telling you, Senali, his blood pressure is 110 by 70. 110 by 70. Right. What do you think? Does it look okay?
So the blood pressure is kind of systolic is okay, but the diastolic is high.
Right. So 110 by 70 is okay, isn't it? 110 by 70 is okay. When do you say that the child has got hypertension? Do you expect hypertension in dengue anyway? No. What you expect is hypotension, isn't it? Right, hypotension. So 110 by 70 for a 5-year-old child is okay, isn't it? 5-year-old child is okay. Does anyone know how to decide the normal blood pressure of a child? There is a formula. There is a formula, right? What is the, Senali, can you remember?
So I'm not sure, sir. Blood pressure, age plus body weight. I'm not sure, sir. I can't remember.
Yeah, so it's 80. It's 80 plus age multiplied by 2. 80 plus age multiplied by 2, right? So 80 is a constant. Age is 5 here. 5 multiplied by 2 is 10. So 10 plus 80 is 90. So any blood pressure around 90 or more, I'm talking about systolic, 90 or more is normal for a 5-year-old child, right? So this child's blood pressure is 110 by 70, which is normal, right? Which is normal. All right. So as long as blood pressure is normal, right? And we don't think that child is in shock, right? Heart rate is high. Heart rate is high. When you examine, the heart rate was high. When the heart rate is high, right, we are worried that he might go into leakage. He might go into shock, right? He might go into shock, right? Now, suppose you have examined, the parameters are heart rate is 150, blood pressure is 100 by 70, right? So he is not in shock, isn't it? He is not in shock, right? Next point, right? You examined again, right? You went to quarters and came back. When you examined again, now the blood pressure is 110 by 95. 110 by 95. What does that tell you?
So the pulse pressure is low now.
Absolutely. Right. 110 by 95. Pura මොකද්ද මේ? Say, initially blood pressure was 110 by 70, isn't it? 70. Now the diastole has gone up. Diastole has gone up. When the diastole goes up, Senali was telling a fancy word, pulse pressure, right? What is pulse pressure? Pulse pressure is the difference between systolic and diastolic blood pressure. Systolic and diastolic blood pressure, right? Now, when the diastolic blood pressure goes up, pulse pressure will narrow down. Pulse pressure will be narrow, right? When pulse pressure narrows and when it is less than 20, pulse pressure එක මෙහෙම අඩු වෙලා ගිහිල්ලා 20ටත් වඩා gap එක අඩු වුණොත් 20ටත් වඩා gap එක අඩු වුණොත් that is called compensated shock, right? What is that called? Compensated shock, right? Why do children get compensated shock? Why does the diastolic blood pressure goes up, right? Go up because of vasoconstriction. Vessels constricted. When the vessels are constricted, peripheral resistance goes up, then diastolic blood pressure will go up. Diastolic blood pressure will go up, right? Senelli was telling the earliest sign of leakage is tachycardia. Earliest sign is tachycardia, right? ඒක තමයි පළවෙනි weapon එක. What is the second weapon that a child will use to prevent him going into shock? Vasoconstriction. How do you know vessels are constricted? Pulse pressure will narrow down, right? Pulse pressure will narrow down. This is what happens, right? When the pulse pressure is narrow, when it is narrower than 20, that is called compensated shock, right? Suddenly, suppose nurses were telling blood pressure is 110 by 70. Sorry, 110 by 95. Are you worried?
Yes, sir.
You are worried, right? You are worried that the child has gone into compensated shock, right? You are worried, but you were busy with making a TikTok video. You could not come to the ward, right? You could not come to the ward. In 2 hours' time, you came, right? You came. Now the situation is this. Blood pressure is 80 by 50. Blood pressure is 80 by 50. All right. Pulses, very weak, almost non-detectable, right? Peripheries are very cold. Peripheries are very cold, right? Was that understood? Now what is the situation, Senali?
Patient has gone to decompensated shock.
Absolutely. Child has now gone into what? Decompensated shock, right? The child was waiting for Senali to come. Senali enakang tachycardia හදාගෙන vessels constrict කරගෙන බලාගෙන හිටියා. Senali ආවේ නැහැ. Right? Then what happens? You can't keep on constricting vessels. When you keep on constricting vessels, what happens? The tissues will be hypoxic. Then mage අතට එන blood vessels constrict කරත් මොකද වෙන්නේ පුතා? The hand is not going to get blood. But that is fine. You are sacrificing hand blood by sending that to the brain, right? Brain is very important. But when it keeps on happening, the hand will be hypoxic. Hand is going to produce lactic acid. Methanol lactic acid හැදෙනවා. When you produce lactic acid, it is a potent vasodilator. Vasodilator, right? At one point, hand is going to say, I am fed up of keeping the vessels constricted. Now the lactic is asking me to dilate. I'm so tired, I'm going to dilate. Now that is called what? Decompensated shock. When that happens, the whole blood pressure will collapse, pulses will be very weak, peripheries will be cold. Now that situation is called what? Decompensated shock. Was that understood? That situation is called decompensated shock, right? Is it an emergency, Senali?
Yes, sir. We have to
Absolutely, yes. Yes, so that's an emergency, right? So where are we now? දැනට මොනවද දන්නේ පුතා? We know febrile phase එකේ clinical features දන්නවා. When to admit, we know. Then clinical features of leakage. Ayesha was talking about that. Clinical features of leakage, that is pleural effusions and ascites. Then we know the features of shock. Senali was discussing it, describing it. First sign is tachycardia. Then there will be narrow pulse pressure. That is called compensated shock. How narrow, Senali? Less than, what is the cutoff?
25 is suggestive, and if it's less than 20, it is
less than 20 is definitive, right? Pulse pressure කියන්නේ මොකද්ද පුතා? The difference between systolic and diastolic. When you see SBA questions, single best answer questions, තියෙනකොට බලන්න pulse pressure එක කීයද? Systolic diastolic difference. If it is less than 20, child has gone into what? Grade 3 or compensated shock. If you have not done anything at this point, මේ වෙලාවෙත් මුකුත් කරේ නැත්තම් මොකක්ද වෙන්නේ? Child is now going to die. He might go into decompensated shock. Suddenly, what are the features of decompensated shock?
3D pulse pressure, 3D
Yeah.
pulse,
3D
and
pulse.
blood pressure.
Yeah, blood pressure will be very low or unrecordable,
Detect.
right? Blood pressure will be very low or unrecordable, right? Okay, so yes, so essentially that's basically it, right? Yeah, so when Senali was, now when she came to Senali, if you don't mind, right? When she came to Viva classes, she told sir, මට නම් ප්‍රශ්න අහන්න එපා මගෙන්. I feel so anxious, right? And then she told, no, I'm not going to come to your like big classes. අර ළමයි 20ක් විතර අරගෙන කරන mini clinics. I'm only going to come to them because I don't want to expose to big number of people. Now how she is, she's very confident and she got, what was your rank, Senali? You were 5 or 6?
5th, sir.
5th. That's a good rank, isn't it? Right? So what is the story that you have to learn from Senali? Initial anxiety, feeling nervous is all normal. All normal. You can go a long way. Right? The first 10 එකේ කට්ටිය ඒ හැමෝම මොකද? මුලින්ම බයෙන් හිටියේ, but then they managed to do. And there is another one I just wanted to introduce her. If anyone, I don't think after I introduce her, you are not going to complain anymore, right? I might introduce her next, right? She is Doji, right? Doji is one of our local graduates, right? Doji is from Nepal, right? Doji is from Nepal, and then she followed the local university. And the good thing is what? Not knowing Sinhala at all, right? When she became a medical student as a first year, she started the journey, ended up with a distinction in pediatrics after taking histories from Sinhala patients. How good is that, right? So if you are telling I am Tamil, so I don't know Sinhala, or if you are telling I am Sinhala, I don't know Tamil. Oh, I was graduated from Russia, I was graduated from China, hardly any Sinhala exposure, ඒ නිසා මට බෑ. No, you can't say that, right? You can't say that because Doji managed to do everything, right? Now, I would ask, now, like, thank you, Senali. Now, how much are we aware about dengue? Then dengue වල මොනවද දන්නේ පුතා? We know about dengue fever and their clinical features, right? When to admit a child with dengue, we know, right? When to admit a child with dengue, we know, right? ඊළඟට මොනවද දන්නේ? When you admit, right? Or even before you admit, how to examine a child, right? dengue ළමයිගේ examine කරන්න ඕනේ මොනවද? Ill looking or well looking, febrile, the rash, right? Any tenderness in the liver, hepatomegaly, and then look for features of ascites like අපි බලන්න ඕනේ ascites තියෙනවද කියලා බලන්න, pleural effusions තියෙනවද කියලා බලන්න. So those we need to check. And then Senali was talking about look for features of shock. It could be compensated shock, where the tachycardia with narrow pulse pressure, or decompensated shock. Decompensated shock කියලා කියන්නේ මොකද්ද? There is very poor blood pressure with what? With 3D pulse or undetectable pulse, right? Now, can this come, right? Then ඊළඟට අහන්න පුළුවන් ප්‍රශ්නයක් මොකද්ද? Now, a child presented with dengue or features of dengue, how are you going to evaluate this child? How are you going to evaluate this child? This could come as a what? Essay question for locals. This could come as an emergency scenario for foreign graduates, foreign ERPM students. So we'll see how to approach to this child, right? So this question, right? It is like the summary of what we have already discussed. The we now know how to evaluate a child with dengue. ඒ part එක ඉවරයි. ඊළඟ segment එකට අපි යන්නේ මොකද පුතා? We are now next going to management. Right. Before we go to management, we will have a summary of what we have discussed with this topic. What general, the holistic evaluation of a child with suspected dengue. Right. Thank you, Senali. Doji, are you there?
Yes, sir.
Right. Yes. So Doji, suppose you get Doji, are you happy to? Yeah. Okay. If you get
Yeah.
this question, right? If you get this question, what is the question? How to evaluate, right? How to evaluate a child with suspected dengue? How do you do that?
So evaluation mainly involves 3 points, which made number 1, the history, and then number 2, the examination, and number 3, the basic investigation. So
Yeah.
if we are giving that an SCQ, we have to elaborate on each of those 3.
Yes. Shall we stop at that point? Right. She was telling a very valid point. Evaluate. How to evaluate. Doji, I think your signals are poor. I don't mind if you switch off the camera. That might make things better. Right. So what did she say? When you are asked, how do you evaluate QMR, right? She gave a very valid point. What? Don't just say, right? Don't just say, I will do full blood count, this and that. You will say, evaluation involves 3 main parts: history, examination, and investigation. History, examination, and investigation. Yes, Doji, go ahead, please.
So in history, we have to elaborate on the presenting complaint. So in this case, the presenting complaint is on fever. So we can explain about the fever patterns, because if there has been a continuous fever, then it's most likely dengue fever. But if there's a sudden drop, it could indicate a critical phase, a leaking phase, or if there has been a high spiking fever in between the continuous fever, it could also indicate there is a secondary infection after the dengue fever as well. And then we can also elaborate on the systemic symptoms.
Dengue is sorry. I would like to disturb you for a second, Doji. Now, fever. Then balanda. That is why she has got a distinction. Distinction for a reason. Distinction for a reason, right? මොකද්ද? අපි කියන්නේ මොකද්ද? අපි කියන්නේ මම නම් කියන්නේ නැහැ, right? Fever, right? Fever තියනවාද කියලා බලනවා කියලා විතරක් මදි, right? As Doji very correctly told, whether it's a continuous fever, only fever. That could be febrile phase of dengue. Sudden drop in fever, no fever. Sudden drop in fever might indicate that the child has gone into leakage. Right? Leakage එකට යනකොට මොකක්ද වෙන්නේ පුතා? Fever drop වෙනවා. Right? Fever drop වෙනවා. Or child was having fever, all of a sudden fever spikes are now different, right? Different fever spike pattern එකකට ගියා. That might indicate what? Secondary infection. That might indicate secondary infection. But now when you are giving an answer, right? Answer එකක් දෙනකොට පුතා කොහොමද examiner impress කරන්නේ? Right? ලකුණු ගන්නේ කොහොමද? Then short case එකේ හරි long case එකේ ඇහුවොත් history එක අහනකොට examiner අහනවා, okay, why did you want to ask if the child was having fever? එතකොට උත්තර දෙන්න ඕනේ කොහොමද? If the child was having like regular fever, I might think that he is in dengue fever only. If the fever suddenly drops and child deteriorates, that means child has started leaking. Very likely he has started leaking. If the child all of a sudden starts to have high spiking fever, maybe on top of dengue, he has got a secondary infection. Dengue වලදී මොකක්ද වෙන්නේ පුතා? There is a WBC drop, leukopenia එකක් එනවා. On top of that, you can get bacterial infection, right? So therefore, analyzing fever is very important with reasoning, right? essay එකක් ලියනකොටත් එහෙම තමයි ලියන්නේ. Yes, Doji, continue please.
Then for the systemic history, we can ask the mother. First of all, she will be able to understand what the child is experiencing. Moreover, if since the child is 5 years old, the child will be able to explain and localize the pain as well. So we can ask about the myalgia, the headache, and nausea and vomiting is also very important, because it is a warning sign, and it warrants an early admission. And then most important thing is tender hepatomegaly. So if the child complains about abdominal pain, it indicates that the child is most likely in critical phase. So that will prompt us to be more urgent with the investigations and admission as well. Then the other things that we have to ask is about the child's behavior to the mother, whether the child has become more lethargic or more irritable. That is also very important. Any changes in feeding pattern is also very important. And another thing that we have to highlight in history is the past medical history. Like if the patient has any serious comorbid illnesses like CKD or nephrotic syndrome or any obesity, then that will also alter the management and the site of management as well. And then another thing is any drug histories. And if the patient is currently on any prednisolone, like any other steroids or NSAIDs, then we might have to withhold that. And if the mother has already started giving paracetamol, is that why the fever patterns are changing? That is also something that's important to highlight. And another important thing in the history is the social history.
Excellent. You see, the way how you take the history, social history ke me wahanda, past medical history ke me wahanda, drug history ke me. So everything should be very relevant, right? Everything should be very relevant. People who get good marks will ask relevant questions. Important negatives, important positives. When they write the essay kat to the point tamaliyanne. They don't get distinction because they write a long essay, but to the point. Pediatrician te hitenawa, the essay was written by one of my colleagues. The doji kata karana nikan එයාට zoom එක දීලා මට යන්න. So she's talking with that confidence, right? So that is what the examiners would expect from a person who gets high ranks, distinctions. ඒක තමයි level එක. Right, now Doji, now history is that. Examination, what do you examine? That is a part of your evaluation, isn't it?
Yes, sir. So with any pediatric examination, we have to always start with anthropometry. So we have to get the body weight and height, because if the patient is obese, we have to depend on the ideal weight rather than the actual weight. So maintenance fluid calculation is very important in dengue. So for that, we need the body weight. And on inspection, in general inspection, we have to look at the alertness of the child, the behavior of the child, whether the child is, the appearance of the child, the color, whether the child is flushed or not, and is there any rashes or not, and any other bleeding manifestations like gum bleeding or not. And then if we look at the more focused systemic examination, then we have to look again at the pulse rate, the pulse pressure, the pulse rate, pulse volume. And then we can also feel the extremities and see whether if there are cold extremities or not, and validate it more with capillary refill time. And then we can also see the blood pressure. And then we can also, since the pleural effusion is another complication, we have to check the respiratory rate, and we have to look for any signs of respiratory distress. And we have to do a full respiratory examination, as mentioned earlier. And then we also have to do the abdominal examination, as mentioned earlier, with all the tender hepatomegaly, ascites in mind. And then we can also check the temperature of the child, and we can start monitoring the temperature chart as well.
Excellent. Excellent. Now, when she was explaining, බලන්න හැම එකක්ම දැන් body weight එක අපි නම් නිකන් කියයි weight එක බලනවා. Right? See how you are going to gain marks from that bit. Right? Body weight එක බලන්නේ නිකන් නෙවෙයි. Right? We need to check the weight because for fluid calculations, weight is important in dengue. Right? If he is obese, we need to take the adjusted weight than the actual weight. තමයි පොඩි චූටි point එකක් ලකුණු ගන්න හදාගන්න විදිහ. Right? So this is what we need to learn, especially when we write Viva and when we do essay. Sorry, when we talk in Viva and when we do essay. ඊට පස්සේ මොකද වෙන්නේ? systemically ගියා. Generally, it looking the lethargic. And then she went to signs of leakage බලන එක. Right? Leakage එක බලන්න ගියා. And then shock. Right? ඩෝජි කතා කරනකොට මට නිකන් මතක් වෙන්නේ අර සිරිගෙන් ප්‍රශ්නයක් ඇහුවම iPhone එකේ gives the exact answer. So අර ඒ වගේ to the point කතා කරගෙන යන්නයි තියෙන්නේ. So that is what you need to pass the exam. Right. Okay. Right, Doji. Next bit is what? ඊළඟ part එක මොකක්ද වගේ evaluation?
Investigations, sir.
Yeah. How will you investigate a child with suspected dengue?
So the most relevant investigation is, number one, the full blood count. And in the full blood count, we're mainly looking at the platelet count and we're looking at the hematocrit count, because according to the guideline, these are the two variables that we look for in the criteria of admission. And then since in this case, the child is only on the second day of fever, we can also conduct a dengue antigen test, rapid test as well. And then another important test that we have to do, especially in children, because they can be leaking despite having platelet above 150, is ultrasound abdomen and chest for any signs of ascites, pericholecystic fluid, pleural effusion.
Yes, now see, when she is talking, she is always relating to this patient. In this case, because the patient is presenting on day 2, dengue antigen is relevant, right? Look for features of ascites by doing an ultrasound scan abdomen. එහෙම කියලා නතර කරන්නේ නැහැ. She also says expecting pericholecystic fluids, ascites and effusions, right? You see the next level of answering, right? මොකක් හරි එකක් කියනවා, expected findings ටිකක් එහෙමම කියලා දානවා, right? So that is how you get better marks, right? Any other investigations that you would do, Doji? Suppose this child came on 6th day of fever.
So in that case, then dengue antigen test is not very effective, but the child is most likely in the leaking phase. So in the leaking phase, we can also do serum albumin test, and then we can also do serum cholesterol, non-fasting serum cholesterol levels. If the patient is leaking, then the serum albumin will be less than 3.5, and even the serum cholesterol will be less than 100 milligrams per deciliter.
Yes. So if the child is leaking, there are some other investigations that you can do. Albumin will leak out, so albumin level will be low, right? Cholesterol will leak out, so cholesterol level also will be low, right? Cholesterol adueno, albumin adueno. So that's what. And then after 5 days, you can also do what? Dengue antibodies, isn't it? You can also do dengue antibodies. Dengue antibodies will be positive in a child with leakage, right? So then මොනවද අපි දන්නේ leakage එකේ or when a child presents with dengue, how do you evaluate කියන ප්‍රශ්නය අහුවම emergency viva එකේ හරි නිකන් viva එකේ හරි essay එකක හරි you start with history, go to the examination, then go to investigations. And when you say investigations, when you say examination, when you say history, you need to say why I asked this, you need to say why I checked this, right? Examination, you need to say why I did this test, right? So this is what we need to do, right? You can remember when we had an essay discussion course with Doji, and also we discussed essay එකකදී this is how you have to write the essay, distinction type essay gun essay වලට that is how you do, right? And then when it comes to clinical exams, history. Now, Doji, would you like to take a small dengue history from me in Sinhala?
Okay, sir.
Mm-hmm.
Mm.
You can start.
Please excuse my pronunciation and some grammars.
That's okay.
අයුබෝවන් අම්මා, අද ප්‍රශ්නය මොකක්ද තියෙනවා?
මෙයාට උණ තියෙනවා ඩොක්ටර් දවස් දෙකක් ඉඳන්.
මේ උණ කොහොමද පටන් ගත්තා? එකපාරටම පටන් ගත්තද නැත්නම් හැමින් පටන් ගත්තා?
හෙමින් ඩොක්ටර් දැන් දවස් දෙකක් හෙමින් තියෙනවා උණ.
හෙමින් දිගටම උණ තියෙනවද? නැත්නම් මේ අඩු වෙනවා, ආපහු එනවා මෙහෙම තියෙනවා?
අඩු වෙන්නේ නෑ ඩොක්ටර්. 99ට 100ට වගේ තමයි උණ තියෙන්නේ.
ඔයගේ මෙෂර් කරාද?
ඔව්
චෙක්
මෙෂර්
කරාද?
කරා ඩොක්ටර්. උණ
හරි.
කට්ටකින් බලනවා.
හරි. මේ උණ පටන් ගත්ත පස්සේ ඔය වෙන මොකුත් බබාට වෙන මොකුත් ප්‍රශ්නයක් තිබ්බද? ඔළුව කැක්කුම, බඩ කැක්කුම මෙහෙම මොකුත් වෙන මොකුත් රෝග ලක්ෂණ තිබ්බද?
Are you impressed the way how she's talking, right? ඔළුවේ කැක්කුම බඩේ කැක්කුම වෙන මොකුත් රෝග ලක්ෂණ? Yes, ඔළුවේ කැක්කුම තිබුණා ඩොක්ටර්. බඩේ කැක්කුමක් තිබුණා. ඔව්. ඇස් යටත් පොඩි කැක්කුමක් තිබුණා.
හරි. ඊට පස්සේ මේ බබාට මේ කැස්සෝ වගේ මෙහෙම මොකුත් තියෙනවද? ටොයිලට් හොඳටම යනවද?
කැස්ස නෑ
මෙහෙම
ඩොක්ටර්.
කැස්ස
ටොයිලට් යන එක normal.
ටොයිලට් යන. මුත්‍රා කොහොමද? මුත්‍රා යනවද?
පුත්‍රා හොඳට යනවා ඩොක්ටර්. කිසි ප්‍රශ්නයක් නෑ වෙනදා වගේම.
හරි. ඊට පස්සේ බබාට රෑෂ් හැමේ පළුව වගේ මෙහෙම මුකුත් ආවද?
හැමේ පළු
හැමේ
ආවේ
රෑෂ්
නෑ.
වගේ ආවෙන්නේ
නෑ
නේ.
ආවේ
හරි.
නෑ.
ඊට පස්සේ මේ ප්‍රශ්නේ පටන් ගත්ත පස්සේ බබාට වමනේ වගේ මුකුත් තියනවද? කැම කන්න අපිරියයි වගේ?
වමනේ පොඩ්ඩක් යනවා ඩොක්ටර්. කෑම කන්නෙත් නෑ එයා දැන්.
හොඳට කැම කන්න බෑ.
බෑ.
හරි. ඊට පස්සේ බබා කොහොමද? බබා ගොඩක් නීදීද? ගොඩක් අඬනවද?
එහෙම අඬන්නේ නෑ ඩොක්ටර්. ටිකක් නිදි මත වගේ තමයි ඉන්නේ.
ශක්තිය අඩු වගේ මෙහෙම පොඩක් නොටිස් කරාද?
පොඩ්ඩක් ඔව් එනර්ජි එක අඩුයි වගේ තමයි. ශක්තිය
හරි.
අඩුයි.
හරි. ඔයගේ ළඟ මෙහෙම මෙහෙම මේ ඩ්‍රේන් ස්වාම්ස් මෙහෙම ගොඩක් තියෙනවද?
මට තේරුන්නේ නෑ ඩොක්ටර්.
ඔයගේ මේ මස්කිටෝස් ගොඩක් ළඟ ඔයගේ ළඟ මෙහෙම ගොඩක්
මොස්කිටෝ
මස්කිටෝස්
මදුරුවෝ ඉන්නවා ඩොක්ටර් අපේ
මදර
ගෙදර ඉන්නවා.
ගොඩක් ඉන්නවද? ඊට පස්සේ මේ ඔය වෙන කොහෙද ඔයගේ ළඟ කවුරුත් ඔයගේ මෙහෙම ඩෙන්ගි වගේ නැත්නම් උණ වෙන මොකුත් ප්‍රශ්නයක් තිබ්බද?
අපේ මේ නෙක්ස්ට් ඩෝ අපේ නේබර්ටත් තිබුණා ඩොක්ටර් උණ.
ඩෙන්ගි තිබ්බද?
ඩෙන්ගු. ඔව්.
හරි. ඊට පස්සේ බබා වෙන කොහෙද ඉලියට ගියේ නෑනේ?
නෑ ඩොක්ටර් මෙයා ගෙදරම තමයි හිටියේ.
මෙහෙම ප්‍රශ්නයක් පළවෙනිද නැත්නම් කලිනුත් මෙහෙම ඩෙන්ගි වගේ ප්‍රශ්නයක් ආවද?
නෑ මේ පළවෙනි සැරේ.
හරි. ඊට පස්සේ වෙන මොකුත් ප්‍රශ්නයක් නෑනේ?
වෙන මොකුත් නෑ ඩොක්ටර්.
බබා වලට කලින් වෙන මොකුත් ප්‍රශ්නයක් වගේ හොස්පිටල් එක්ම කරාද?
නෑ මේ සමා මුලින්ම ඇඩ්මිට් කරේ මේ සැරේ.
මේ සැරේ හරි. ඊට පස්සේ කලින් බෙහෙත් මොකුත් බිව්වේ නෑ? මුකුත් අමාරු මුකුත් තිබුණේ වෙන. හරි. ඊට පස්සේ ඔයගේ ගෙදර මේ හොස්පිටල් ළඟද?
ගෙදර හොස්පිටල් එක ළඟ තියෙන්නේ ඩොක්ටර්. walking
හරි.
distance.
ඔයගේ walking distance එකේ මිරිතු කීයක් වගේ එන්න ඕනේ?
විනාඩි 10න් එන්න පුළුවන් ඩොක්ටර්.
හරි. එමර්ජන්සි මුකුත් තියෙනම් ඔය ඉක්මනින් එන්න පුළුවන් නේ?
පුළුවන් 3 wheel එකක් තියෙනවා ඩොක්ටර් අපිට හදිසි වුණොත්.
හරි. හරි. ඊට පස්සේ බබාට ඇලර්ජිස් මුකුත් තියෙනවද?
නෑ ඇලර්ජි නෑ ඩොක්ටර්.
කෑම වලට බෙහෙත් වලට මුකුත් නෑ.
නෑ.
හරි. ඊට පස්සේ මේ ඔය රසව මොකද කරනවා?
මම ටීචර් කෙනෙක් ඩොක්ටර්.
ටීචර් ඔයගේ පාර්ට්නර් මොකද කරනවා?
එයා හවුස්වයිෆ්.
හරි. ඊට පස්සේ බබාගේ මේ හැමදාම මෙහෙම බ්ලඩ් පොඩක් චෙක් කරන්න එන්න ඕනේ නම් පුළුවන් නේ? මුකුත්
පුළුවන්
ගොඩක්
ඩොක්ටර්.
අමාරු තියෙනවද? හරි.
නෑ හෙට එන්න ඕන නම් බ්ලඩ් බලන්න හෙට එන්න පුළුවන් අපිට.
පුළුවන් නේ? හරි. okay. That's it, sir.
Yeah. So see 5 minutes 6 minutes especially for OSCE. දැන් අපේ අලුත් ක්‍රමයක් තියෙනවනේ පුතා ERPM අයට OSCE කියලා 10 minutes නේ OSCE. So they might ask take a focused history, right, from this child presenting with fever, right? Suspected dengue, take a focused history, right? Full station is 10 minutes. එතකොට you might have to finish it in 6 minutes. Then Dojit 5 minutes gate nani, right? It did not even take 5 minutes, but she covered, right, everything: presenting complaint, history of presenting complaint, past medical history, any previous admissions, social history, all those, right? All those were covered, like important ones, right? හැමේකම cover කරන්න බෑ විනාඩි 5න්, right? So that's the kind of history, right? So I think now when Doji came to our practical sessions, right? Sigma K practical sessions වලට ආවම they were Sinhala patients and Tamil patients and Muslim patients, but she managed to take the history. She managed to examine children, right? Examine කරනකොට මේම අත උස්සන්න, කකුල උස්සන්න, හොඳට හුස්ම ගන්න, right? අර commands ටිකක් දෙන්න එපා. She managed to ask all the commands, right? So now if you are telling, right, මම මෙන්න මේ රටේ ඉන්න නිසා මට ඒ command දෙන්න බෑ මෙහෙමයි කියලා, so this is an example, right? I just wanted to get her down for 2 reasons. Number one, there are enough and more other students who got distinctions, right? Distinctions local la උනේ තරම් ඉන්නවා distinction ගත්ත අපේ. But I wanted to bring Doji because she got a distinction without being Sinhala as her first language, right? Sinhala නෙවෙයි Tamilut නෙවෙයි, right? මොකක්වත් නෙවෙයි. එහෙම වෙලා වෙන රටකිනුත් ඇවිල්ලා distinction උත් තරන් ගියා. Right? She was thinking what to do, but then I managed to convince her a little to do pediatrics. So she will be a pediatrician soon, like in 5-6 years time. Yes, thank you, Doji. Thank you very much. We'll see you soon.
Okay, sir. Thank you, sir.
Right. Yeah, thank you. Right. Okay. So now where are we? Right. Where are we? We know how to take the history, right? How to take the history, how to examine the child, and then what investigations we are going to do. Right. Now, if we go back to our document, right? The document now we know the features of critical phase of dengue, right? Critical phase of dengue. And then we also know features of shock, right? Features of shock. Now, what are we going to do? Now we need to know how to manage, right? How to manage, right? Then පුදා management එක බැලුවොත්, right? How do children present? දැන් මේක මම එක වචනයක්වත් අයින් කරන්නේ නැහැ, because why? Anything can be tested in the exam, right? Anything can be tested. You know, they will present with high fever for 2 to 7 days, headache and retroorbital pain, nausea and vomiting, arthralgia, myalgia, and flushed appearance is possible, and child might have a rash and positive tourniquet test. We'll come to that point a little later. Now this one, right? Some children with dengue might have low WBC, right? And platelet count could be low, right? They also can have hemorrhagic manifestations like gum bleeding, purpura, gastrointestinal bleeding, hematuria, adolescent girls, menorrhagia, all these are possible, right? And they also can have tender hepatomegaly. The liver will be tender when you examine. If that is there, very suggestive of dengue hemorrhagic fever. Dengue hemorrhagic fever කියන්නේ මොකද පුතා? Dengue with leakage. Dengue with leakage. By the time they go into hemorrhagic fever, usually their platelet count will be less than 100,000, right? Platelet count will be less than 100,000, right? Now, when you get a child with suspected dengue, one of the tests that we do is what? Dengue NS1 antigen. NS1 antigen, non-structural protein. NS1 කියන්නේ ඒකට තමයි. Non-structural protein, right? So here, when you do NS1 antigen, right, it especially during the first 3 days, if you do, it is likely to be positive. However, negative NS1 does not exclude dengue, right? Negative NS1 does not exclude dengue. That is something that we need to know, right? That we need to know, right? And then full blood count, what do you expect? Full blood count, you can write. Full blood count, what do you expect? Usually, first day full blood count is essentially normal, right? Essentially normal. We tend to do full blood count, right? Usually after 48 hours. After 48 hours. What do you expect, right? The child might have low platelets, less than 150,000, right? Low platelets, less than 150,000. They also can have what? Leukopenia, low WBC count, right? Low WBC count, right? Low platelet, low WBC count. So that is what you are going to see, right? Dengue antibodies are usually tested after 5 days. Dengue antibodies are usually tested after 5 days. What we commonly test is IgM. IgM will be positive in dengue usually after 5 days, right? When to admit, right? When to admit, that's another MCQ. You admit any child less than 150 platelet count. And if the hematocrit, right, packed cell volume, right, if the packed cell volume is rising more than 10% of baseline, right? What is the baseline packed cell volume in a child? Baseline is 35%. Puda. Baseline, baseline. Hematocrit 35%. Normally 35%, right? If it has gone up by 10% of that value, Puda, listen to this very carefully. 10% of that value. Mocha the normal 35. 10% of 35 is 3.5. 3.5, right? If the hematocrit has gone up by 3.5%, right? So 3.5, right? Normal 35. If it has gone up by 3.5, that is 10% increment, right? Was that understood, right? If it has gone up by another 10% of baseline, right? 35, another 3.5 is 10%. That is like 38.5. If that is the case, you will admit, right? Any child presenting with vomiting, lethargy, mucosal bleeding, no urine output for last 6 hours, severe abdominal pain, cold extremities, right? Clinical features of fluid accumulation like pleural effusions, ascites, Ayesha QA, right? Or if there's tender hepatomegaly, you admit those patients, right? Was that understood? This is what you do, right? Consider early admissions, right? If the patient is having, if the patient is an infant, obese patient, other comorbidities like nephrotic තියෙනවා නම්, chronic renal failure තියෙනවා නම්, right? Adverse social circumstances, you will admit, right? Then what are the types of dengue? You know, undifferentiated febrile illness. This might not be dengue, and then it could be dengue. So dengue fever, dengue hemorrhagic fever. අපි ඒකට කියනවා leakage. Leakage might go into shock. And then you have something called expanded dengue syndrome. It is not just dengue only, dengue with myocarditis, dengue with encephalitis, right? So that is expanded dengue syndrome. That's a different thing, right? So that's it. Now, what are the phases of dengue? Dengue febrile phase. Febrile phase එක තමයි පසිඳු history ගත්තේ. Febrile phase. And then critical phase. Ayesha කතා කරේ, that is critical phase. Critical phase might go into leakage. Then these children will recover. Recovery phase එකට අපි කියන අනිත් නම මොකද්ද? Convalescent phase, right? Convalescent phase, right? If the child is having fever only, right? Fever only. Management of febrile phase. Febrile phase. One of them baba awa, no leakage, nothing, right? How are you going to manage this child, right? Fever එකක් විතරයි තියෙන්නේ, වෙන මොකුත්ම ප්‍රශ්න නැහැ, right? Only fever, right? So how are you going to manage this child, right? Now, what is the management, right? It is recommended to keep a cannula in situ, right? Cannula එකක් දාගෙන තියාගන්න. Febrile phase එක විතරයි තියෙන්නේ. Ensure adequate fluid intake, right? Adequate fluid intake. Oral fluids are recommended if oral intake is good, right? Febrile phase now, you don't necessarily have to give IV fluids. Oral is good enough, right? Oral is good enough, right? If the patient is vomiting or dehydrated, you might consider IV fluids. Other than IV fluids, fluid deca, you usually give 5% dextrose in normal saline with 5% dextrose. Adequate physical rest is needed, and you give paracetamol. What is the maximum dose? 60 milligrams per kg for 24 hours, right? What is the paracetamol dose at a given time? It is 15 milligrams per kilo. 15 per kilo is the single dose. You can use such 4 doses maximum, right? Avoid NSAIDs and steroids, as Doji was very correctly telling. NSAID and steroid can cause bleeding, so you don't give ibuprofen, steroids, diclofenac sodium, you don't give naproxen, you don't give, right? So that's it. And then you need to monitor this child. Monitor, right? How often do you usually monitor? Every 4 hourly, right? You monitor every 4 hourly. What do you monitor? Pulse, blood pressure, urine output, those, right? Now, when you check the urine output, you need to see if this urine output is normal. What is the normal urine output? Normal urine output is above 0.75 ml per kg per hour, right? 0.75 ml per kg per hour, right? Per kg per hour. So this is how much you give as the urine, you expect as the urine output, right? 0.75 ml per kg per hour, right? Anything between, right? Anything between 0.75 to, like 0.5 to 1 is okay. 0.5 to 1 ml per kg per hour is okay. So over 0.75 is good, right? And you do full blood count morning and night, right? In dengue fever only, right? And then we also do hematocrit or pack cell volume, right? How often? Twice a day. If you are the house officer, if Angelo is the house officer, Angelo will do PCV morning and night. We have PCV machines, microhematocrit readers in the ward. So you can do it inside the ward, right? Full blood count again, morning and night, you send it to the lab, right? Then how do you detect? Okay, now the child is going into leakage. Then leakage එකට ගියා කියලා කොහොමද කරන්නේ? Now, as Ayesha told, you will see features of fluid leakage, pleural effusions තියයි, ascites තියයි, those. And full blood count will show usually at this point platelet count will be cross the 100,000 mark, right? Platelet count එක බහිනවා 100ට වඩා, right? Platelet count will be less than 100,000 generally. Hematocrit will further increase. Hematocrit will further increase, right? If it is more than 20% from baseline, right? More than 20% of baseline value, then you know that the child is leaking, right? Angelo, what is the baseline hematocrit of a child?
So it's 35.
35. Then if it has gone up by another 20% of baseline, what is the value?
So in the case of 25, it will be more than almost 7, so 42%.
Yes. Did you understand? Now, if the normal hematocrit is 35, normal hematocrit එක 10% වලින් වැඩි වුණොත් කීයද? 3.5. 20% is 35 into 20% is 7, ne? 7, right? 7. So if it has gone up by another 7, so that is how much? 35 plus 7 is 42, right? In the exam paper, if you see a hematocrit value more than 42%, that means the child is leaking. That means the child is leaking. Was that understood? So this is how you look for features of leakage. What are the other things? If you have a scanner, now Nigambo Hospital, we have scanners in ward. Ward එකේම scanners තියෙනවා. House officers can do the scan, right? House officer scan කරනවා, right? We give that training. So මොකද්ද house officer scan එක කරලා බලන්නේ? You do ultrasound scan chest to look for pleural effusions, and then you do ultrasound scan abdomen to look for pericholecystic fluid. Pericholecystic fluid. ඕක තමයි බලන්නේ scan කරලා. That is one of the earliest features of dengue leakage, pericholecystic fluid in the abdomen scan. And then as Doji was telling, you can also do blood investigations to look for leakage. Blood investigations to look for leakage. මොනවද කරන්නේ? Blood investigations, serum albumin, right? Serum albumin can be done, and then you can do serum cholesterol levels, right? Serum cholesterol levels. So this is what you do when it comes to suspected leakage, right? Suspected leakage. Right. Now we know how to manage febrile phase of dengue, right? Febrile phase එක manage කරන්න දන්න ඕනේ. හරි සරලයිනේ. Febrile phase එකේ ලොකු දෙයක් නැහැ. paracetamol දෙනවා. Fluid දෙන්න ඕනේ. Fluid මොනවද දෙන්නේ? Maintenance fluid, right? Maintenance amount of fluid can be given IV or orally, right? IV or orally, and then you need to monitor this child, right? Monitor this child hourly, right? And then leakage. Then we know how to look for leakage. Leakage or clinical features, done, full blood count features, done, ultrasound features, done, right? Now, if the child is leaking, right? If the child is leaking, how are you going to manage? I will ask another house officer. Butsaradi, can you tell us how to manage leakage? Yeah.
So usually, when we suspect, like, so I'm clear, right? I can be heard.
Yeah. We can hear you clear.
Okay. So usually when we suspect leakage in a child, like we expect it to happen over like a course of 48 hours. So when the child is leaking, our main concern is managing the fluids. So the leakage phase is mainly guided by, the fluid quota, what we call the fluid quota. And this is usually, there's a formula for this, but if I am like brief on it, usually we have to give a maintenance dose, like a maintenance fluid dose. And to that we have to, there's around like a 5% deficit. So this 5% deficit is like the amount of like there's a certain amount of body weight that is lost in the child.
Yes.
So it is covered by the 5% deficit, and this fluid management will be mainly guided by the weight of the child. and you know, and then like, and also it's also the main aim of giving the fluids is to like avoid you know, complications. For example, like if we have to make sure when we're giving the fluids, you know, you don't give like too much of fluids, because if there's a fluid overload, you know, that the child might go to heart failure. And the other one is like other one we have to, so to guide this, we use the urine output to as like it's like a marker of fluid rate. Yeah. So usually the normal urine output is like 0.5 to around 1 liter per kilogram per hour. So while we're giving these fluids over a course of 48 hours, we monitor the urine output and obviously the other vital parameters as well, you know, the blood pressure, capillary refill time. So we monitor these hourly, these parameters hourly. And yes, so based on the child's weight, we calculate the fluid quota according to the formula. Yeah.
Yes. So the important couple of things that Butsarani told was, right? Butsarani kiwe එකක් තමා, when the child has gone into critical phase, right? When the child has gone into critical phase, you need to monitor the child how often? Hourly. ඒක MCQ එකක්. Hourly monitor කරන්න ඕනි. Then the next thing that we need to know is we need to give a certain amount of fluid. And a certain amount එක මොකද්ද? The name is fluid quota. Right? We'll come to that point little later. We need to give a certain amount of fluid. අර ඒ දවස්වල පෙට්‍රල් නැති කාලේ අපිට දුන්නේ පෙට්‍රල් quota එකක්. Right? ඒ වගේ dengue, if the child is leaking, this is the amount of fluid that you can give. Right? So that amount should be calculated depending on the body weight, right? Body weight. And then she was telling you should not give lot of fluids than needed, because one of the commonest reason for a dengue child to die is what? Fluid overload. Fluid overload. ඒක තවත් MCQ point එකක්. One of the commonest reasons for a child to die with dengue is what? Fluid overload. So you don't have to overload the child. At the same time, you should not make this child to go into shock. ඉතින් ඒකට මොකද්ද බුත්සරණිගේ ප්‍රතිපත්ති ප්‍රකාශය, right? So she is planning to give the fluid quota, right? Fluid quota should be calculated with a certain formula, which I'm going to go through. And then you need to monitor this child hourly, including urine output. And she was very correctly telling urine output should be between 0.5 to 1 ml per kg per hour, right? So that's very good, right? What is your plan? Which hospital are you willing to go?
So I haven't exactly decided, but most probably going to stick to, you know, Western Province.
Western Province.
Yeah.
Western. ඈතට කවුද දොස්තර නැද්ද? Right? ඒගොල්ලෝ නිකන් autopilot යනවා. Anyway, right? So yeah, Butsarani is from Grodno and she passed all 7 subjects in one go, right? So yeah, so good. You might get a hospital in Western Province. Yeah. If you don't get, don't worry. Other provinces are also equally good, right? Other provinces are also equally good. Go to those places. Like after first 1 or 2 weeks, you will get used to that area, right? You will get used to that area. ඊට පස්සේ දැන් Facebook එකේ status දානවා, feeling happy at Sorabora Valley, feeling happy at here, there. So that's how, right? But initially for the homesickness එකත් එක්ක අපි ආසයි ගෙදර ළඟ ඉන්න. Anyway, you have got a very high rank, so you will get, yeah, you want. Right. So yes, thank you, Butsarani. Now, how will you manage critical phase? That's the other question. Critical phase එක manage කරන හැටි. Right? So this is very important to understand. Critical phase කියලා කියන්නේ මොකද්ද? Child has gone into leakage. Right? Child has gone into leakage, right? So if that is the case, management is you need to give a certain amount of fluid to this child. Certain amount of fluid to this child. What is that certain amount? If you can highlight, what is that? Maintenance plus 5% deficit. I'm going to explain it one by one, right? Maintenance plus 5% deficit, right? Okay. So this is the amount that you need to give. Now, we assume that the child is 22 kilos, right? This is the one of the examples, right? 22 kilos now. How do you calculate the maintenance, right? Maintenance fluid එක calculate කරන්න පුතා මෙහෙමයි, right? First 10 kilos of body weight, 100 milliliters per kilo. Next 10 kilos of body weight, 50 milliliters per kilo. Anything more than that, 20 milliliters per kilo. Right. Okay. So first 10 kilos, 100 milliliters per kilo. How much will that be? 1000. Is that correct, Nube? Right. First 10 kilos nang 1 kilo 100 nang 1000 milliliters. Next 10 kilos, 500. Isn't it? Next 10 kilos, 500. Then how many more kilos left? 2 kilos ni. 2 kilos nang kiyada buda. Remaining 2 kilos, 20 into 2, 40. So that is 1000 plus 500 plus 40 is 1540. Was that understood? That is the maintenance. The Butsarani kiwa quota එක හදන විදිහ. Quota has got two parts, maintenance and 5% deficit. Now 5% deficit is easy to understand, right? 5% deficit is you assume that child has lost 5% of his body weight. 5% of his body weight. What is his body weight? 22 kilos. Ne? 22 kilos nang. What is 10%? 10% of 22 kilos is 2.2. Then what is 5%? 1.1. Isn't it? 1.1 kilos were lost. 1.1 kilos. 1.1 kilos is 1100 grams. 1100 grams. 1100 grams is equal to what? 1100 milliliters. The density of water is 1. Vature ganatwe ekaini. Therefore, 1100 milliliters equal to 1100 grams. එමනම් අර බුත්සරණි කිව්ව maintenance is 1550, deficit is 1100. So the total is 2640. Was that understood? Right. Total is 2640. This amount, remember, listen to this very carefully. This amount should be given over 48 hours, right? Over 24 නෙමෙයි, over 48 hours. This amount should be given over 48 hours. If you divide this by 48, right? 48 වලින් divide කරාම මම දැන් මේ divide කරන ෆෝන් එකෙන් 2640 divided by 24, that will be 110 milliliters per hour. Right? Sorry. 2000, where are the 2640. Sorry, again, 2640 divided by 48. That will be 55 milliliters per hour. 55 milliliters per hour over පැයකට දෙන්නේ 55 milliliters. Was that understood? This is how much you should give. Right? But while you are giving 55 milliliters per hour, if the child is not maintaining enough urine output, if the blood pressure was not very good, then what do? You might think of increasing fluids. While giving this amount, if the urine output is excessive, child is getting edema, puffy, then you might reduce fluids, right? You don't have to give this amount every hour. You might increase this amount, you might decrease this amount, but total is this much, right? Total is this much. Was that understood? Right? Biscuit packet එකක් ගෙදර තියෙනවා, right? දවසටම තියෙන්නේ packet එකයි, right? උදේට වැඩිපුර බඩගිනි නම් ඔන්න උදේට ටිකක් වැඩිපුර බිස්කට් කනවා. දවල්ට බඩගිනි නෑ, අඩු කරා. රැට ආයෙ බඩගිනි, වැඩි කරා. So that's the kind of, but you only have one packet, right? You only have one packet. So that's the package. Was that understood? This is how you calculate the amount of fluid you need to manage the critical phase, leakage phase එක manage කරන්නේ කොහොම තමයි. Why over 48 hours? Because critical phase lasts for 48 hours. අර leakage එක 48 hours තමයි යන්නේ. So you need to give it over 48 hours. Was that understood? Yes.
Sir, in the case of the critical phase, we have such a quota calculation, but in the case the child with just dengue fever, how do we calculate the fluid that the baby requires?
Very good. Now, very good question. Critical phase, fluid quota is what? Fluid quota is maintenance plus 5% deficit over 48 hours. Was that understood? Right. Now, the question asked by Angelo is, how much of fluid should we give in febrile phase? Una vitarak tiyenawana, right? So febrile phase only. If the child is in febrile phase only, then how much of fluid do you give? Angelo, maintenance only, right? You give maintenance amount of fluid only over 24 hours, right? Febrile
Thank you,
phase
sir.
now, maintenance only. Critical phase, maintenance plus 5% deficit, right? The other difference is febrile phase, you give fluids over 24 hours. Critical phase, you give it over 48 hours. Was that clear?
Thank you, sir. Yes.
Right. Excellent. Right. So thank you for asking that question. Right. So that's it. Right. So management of critical phase, right? Management of critical phase. Fluid quota is needed, right? Fluid quota is needed within brackets. Maintenance plus 5% deficit. Maintenance plus 5% deficit, right? For calculation, refer to the previous page. Right? So this is the amount. Then we can write this fluid quota is given over 48 hours. This fluid quota is given over 48 hours. Right? Over 48 hours. Right. What is the other thing that you need to know? You need to monitor the child's vital parameters, right? Monitor the child's vital parameters hourly, right? Monitor the vital parameters hourly, right? So that is the other thing that we do, right? Was that understood, right? And then, of course, you need to give paracetamol, this and that, right? And then you need to keep checking PCV, pack cell volume, right? Pack cell volume more frequently check karandone, right? You need to check pack cell volume more frequently, right? CUC, critical phase, right? Monitoring in critical phase, pulse rate, volume, blood pressure, pulse pressure, capillary refilling time, warmer, and make MCQ point PCV 6 hour early. 6 hour early. We can remember febrile phase, PCV twice a day. That is 12 hourly, right? Critical phase, 6 hourly. For our house office, every 6 hours, you need to do PCV when the child is leaking, right? Leaking, the pleural effusions are there, ascites is there, PCV has gone up more than 20%, albumin is low, pericholecystic fluid, that is the leaking child, right? That is the leaking child. And then we know how to manage, right? How to manage fluid quota, monitoring, PCV, right? Urine output. So this is it, right? Was that understood? Right. Now suppose the child is going into, child was like leaking, right? Child was leaking. Butsarani has decided the fluid quota, right? Butsarani gave fluid quota mama calculate kala dunna. So he is now on 55 milliliters of fluid per hour, right? 55 milliliters of fluid per hour. Onna payakata 55 milliliters yana gamang inna. And then Butsarani finished her shift, right? Yeah, Colombo Pathé Hospital hambela, right? So she finished, right? A shift and somebody else is coming. Geetni, are you happy to take over?
Yes, sir.
Yes, Butsarani went home. Thank you, Butsarani, right? Right. Okay, so give me, do you also want a government of Western Province Hospital?
Good morning, sir. Yeah, Western Province, yes.
Western province, no one wants Eastern province, Southern, North Central. Okay, yeah. So Geet me is another student from Grodno who passed all 7 and then awaiting for internship. Yes, yes, Geet me. Now suppose now Butsarani has handed over your university colleague, right? Lucky enough to be your co-HO. Now what? Now this child was leaking. Now the blood pressure is 110 by 95. Right? Blood pressure is 110 by 95. Right?
Okay, so
Heart rate 130. What is your understanding?
So, since this patient is tachycardic and the pulse pressure has narrowed to 15, so less than 20, this patient is most likely in compensated shock.
Yes, we'll
So,
stop at that point. Now, any house officer should be able to understand that bit, right? So Geet me understood it very well. If you did not understand that bit, the patient will die. Patient will die. Now, මොකද එයා කියන්නේ? Blood pressure, right? Blood pressure is 110 by 95. 110 by 95 කියලා කියන්නේ මොකද්ද පුතා? Pulse pressure is 15 නේ. Pulse pressure is 15. Senali was telling when the pulse pressure is less than 20, child is in compensated shock, isn't it? So give me, you think that child has gone into compensated shock, isn't it? Right. If you are the house officer, right, what will you do? This child's weight is 22 kilos. Please tell me exactly what you are going to ask your nurse to do.
so I will ask the nurse to get the access, IV access with the large possible cannula for the age, 5 years. And we have to give 10 milliliters per kilogram per hour infusion of normal saline. So since
Yes.
this patient is 20.
Yeah. Shall we stop at that point? Very correct. Right? Now, what was she telling? You will ask nurse to get a cannula in largest bore cannula possible. If you listen to her very carefully, largest bore cannula possible for her age. Right? For his age. අපි අර medicine වල කියන put large bore 2 cannula, we don't say. That is for medicine. Right? Large bore cannula cannot be accommodated to small children. But you can put a large enough cannula possible according to the child's age. දැන් අවුරුදු 5 ළමයෙකුට නම් you can put a yellow cannula or a say blue cannula. You can't put a pink or gray cannula එහෙම දාන්න බෑ. Right? ඒක දාන්න ලොකු වෙන්න ඕනේ. Right? So you put that cannula. Right? And then she was telling you will ask nurse to give what? 10 milliliters per kilo over 1 hour normal saline. මොනවද දෙන්නේ? Normal saline 10 milliliters per kilo over 1 hour. Mr. කියනවා, if you are working in Horana Hospital, Mr. කියනවා, miss, මෙයාට දැන් cannula එකක් දාලා තියෙන්නේ already, right? අපි දෙන්න ඕනේ මොකද්ද? 10 milliliters per kilo. මෙයාගේ බර කිලෝ 22යි. So miss ගන්න 220 milliliters of normal saline and give it over 1 hour. Give it over 1 hour. You can put it into a burette set එකට දාලා 1 hour දෙන්න පුළුවන්. Right? So this is what you do. Right? When you asked, give me, your nurse did it exactly what you asked. Right? That 1 hour went. What do you do now?
I'll reassess the child's heart rate, pulse pressure, and I'll check the blood pressure as well, and
Yes,
urine
so-
output.
Sorry if I'm disturbing you. So very important word, what she told was when it comes to emergency management, reassess. Reassess. You need to see whether what you have done has made child better. Reassess kala balan. Right? You need to reassess. Suppose, give me, you reassessed. Reassess kara. When you reassessed, still the heart rate is high. Blood pressure is 110 by 98. 110 by 98. This is after 1 hour of normal saline 10 ml per kg bolus. Right? What will you do now?
So, the patient is still in shock. So,
What shock?
still in compensated shock.
Absolutely. Still in compensated shock in spite of giving a 10 ml per kg saline. What do you do now?
So next step, as per the guideline, would be to repeat the same dose over
Yeah.
1 hour.
Yes, you give normal saline over 1 hour again. Normal saline over 1 hour again. So this is what you do. Next, right? Okay. Suppose the child, you have given the second bolus as well, right? Second bolus as well. Still, child is in shock. Grade 3 shock or compensated shock. Tamat pulse pressure aduයි. What will you do now?
So the next step will be to give colloids, where we can give dextran 40.
Yes.
That we have to give, yes,
Go ahead.
10 milliliter per kilogram per hour infusion. That too.
Absolutely. Absolutely. So what did she say? You gave normal saline 10 I am going through the management of grade 3 or compensated dengue shock. Right? Drama එකක් වගේ කරන්නේ ඒක තමයි. Right? So 10 ml per kg over 1 hour first one. If he doesn't get better, 10 ml per kg bolus the second one. Even after that, if the child is not getting better, you give the third one. This time, Geetmi was telling a word, colloid. Colloid දෙකක් කියලා එකක් දෙනවා. What is the name? Dextran 40. Dextran 40 is the colloid. After Dextran 40, right? You usually give Dextran 40 over 1 hour. Dextran 40, බකස් ගාලා bolus එකක් දෙන්නේ over 1 hour තමයි දෙන්නේ. Right? That's the case. Right? So that's the management of dengue grade 3 or compensated dengue shock. If I'm to summarize what Geetmi told, normal saline 10 ml per kg over 1 hour, first one. Normal saline 10 ml per kg, the second one, if he did not respond well to first one. After the second bolus, if the child is still in compensated shock, you go for a Dextran 40. Dextran 40, right? Dextran 40 දෙන්නේ කොහොමද? 10 ml per kg over 1 hour. Was that understood? Right. Give me suppose this child, this time is slightly different, right? You could not come to the ward when you were asked to come, right? In the now you are coming. Now the situation is this. Listen carefully, right? Blood pressure is 70/30, right? Pulse not palpable, right? Extremities are very cold. Child is sleepy, drowsy, right? What is your interpretation?
So, with the undetectable pulse and heart rate that low, the patient is
Blood
going
pressure that low.
Blood pressure that low, patient has gone to decompensated shock this time.
Decompensated shock, yes. How do you manage?
So here the first step would be to give 20 milliliter per kilogram normal saline rapid bolus.
Yes.
And
Now,
yeah.
when you answer, answering should be very precise, like what she did. You have to say 20 milliliters per kilo rapid bolus over 1 hour නෙවෙයි, right? 20 ml per kilo, a rapid bolus should be given. Suppose you have given that rapid bolus, get me. Still, the child is in shock. Still, the child is in shock. Now, what can you do?
So then the option is to give colloids, again Dextran 40. I will, okay. Yeah.
Absolutely. Dextran. Then at the වාට්ටුවේදී නම් Geetmi, when you become a house officer, at this point, you need to call your seniors, right? You need to call your seniors. You need to say, I need to call seniors because dengue shock is an emergency. Even if I'm confident, I need the opinion from seniors to make sure that I don't miss anything and the child is managed the safest way possible. You need to say that I will talk to seniors. Anyway, now what did she say? Decompensated shock. The first step is you give 20 ml per kilo bolus rapidly If he does not get better, you don't give any more saline boluses. Instead, you go for a colloid straight away. What is the colloid? Dextran. Dextran 40. How much? 10 ml per kg over 1 hour. Right? 10 ml per kg over 1 hour. Was that understood? That's the management of grade 4 or decompensated dengue shock. Was that understood? Right? Okay. Thank you very much. Give me. You didn't kill the child.
Thank you, sir.
Right. Okay. Right. So that's the management. So if you go to guideline again, right? Management of critical phase we have already discussed. Management of compensated dengue shock. Compensated dengue shock management එක කොහොමද? Initial fluid resuscitation 10 ml per kg isotonic crystalloid. ඒකට තමයි ගීත්නි කිව්වේ what? Normal saline. Normal saline over 1 hour. Right? Normal saline over 1 hour. If the response is good, right? If the response is good, what do? You might reduce fluid from 10 ml to whatever the amount. If the response is poor, that is where we are worried. If the response is poor, you repeat normal saline bolus again, right? Normal saline bolus again. Was that understood? Right. So this is what you do in case if the child is not getting better. Even after the second bolus of normal saline, if the child is not getting better, you go for dextran 40. Was that understood? You go for dextran 40, which is a colloid. That make it කියලා තියෙනවා ඊට පස්සේ මොකද්ද? You continue to monitor, right? Monitoring PCV, urine output. So all those should be managed accordingly. Now, refer to flowchart 1. So what is that flowchart 1? Right. Compensated shock, narrow pulse pressure, low pulse volume, right? Low pulse volume, narrow pulse pressure තියෙනවා නම් normal saline bolus, right? If the child is not getting better, no response නම්, you go for normal saline again. Even after second bolus, if the child is not responding, you go for dextran 40. Was that understood? That's the management of compensated dengue shock. Decompensated, right? Decompensated, නැත්නම් uncompensated, profound shock. ඒ කියන්නේ මොකද්ද? Unrecordable pulse, low blood pressure. Then what do? You go for a normal saline rapid bolus, not over 1 hour, right? Rapid bolus, right? And then if that doesn't work, you go for dextran straight away. Right? Upeshal, is that clear? Yes. Right. So that's what you do in case of decompensated shock and compensated shock. Then SBA හදන්නේ කොහොමද පුතා? මේකේ එක තැනක නවත්තනවා scenario එක. One bolus was given, child is not improving, what do? Or they might give a case of decompensated shock එකක features ටික දීලා අහනවා, what do you do next? Or decompensated shock, one bolus given, no response, what do? ඔන්න ඔය වගේ තැනක තියලා නවත්තනවා. Right? So that is what happens in dengue management related scenarios. Right. Now the next thing is, right, in spite, now sometimes dengue children might not get better even after, right, adequate fluid resuscitation, right? Adequate fluid resuscitation. Suppose this child, you have given fluid, still not responding, right? Yes. Fahumida, in that case, how will you manage? Do you have any idea?
So then we have to suspect the more sinister causes underlying, like acidosis, bleeding, hypocalcemia, and hypoglycemia-like conditions. Yes.
So what did Fahumida say? If the child is not responding to the shock management එක කරා, he's not responding, right? අපි ඒකට කියනවා fluid refractory shock. If that is the case, right? If that is the case, you are giving fluids. Now Geetni was giving fluids, not responding. එතකොට exam එකේ scenario එක හදන්නේ කොහොමද පුතා? They will say decompensated shock child, they will say blood pressure is 70 by 40, heart rate is like the pulse is unrecordable, right? Normal saline 20 ml per kg bolus given, right? 20 ml per kg bolus given, followed by a colloid bolus. Still the blood pressure is low. Still the blood pressure is low, right? How will you manage? Fluid refractory shock management, right? What am I asking? Now I'm asking from Fahumida. Fahumida, where do you want to do your internship?
Around goals, sir.
Around goal. Oh, there is at least one person who is willing to go out of Colombo. No, even Pasindu was happy to go, right? Around goal. Fahumida again passed all 7 in one go from Manipal. She's the Manipal top, first 10 rankers. So Fahumida, so if the child is having fluid refractory shock, what are your thoughts?
So I have to assess what might be the reason for that.
Hmm.
And I will definitely consult my seniors as well. And I will assess for the acidosis, bleeding, hypocalcemia, and hypoglycemia, whether that is causing this condition.
Yes. In fluid refractory shock, there is a mnemonic, isn't it, Fahumida? There's a mnemonic.
Yes, sir.
What is that mnemonic?
ABCS.
ABCS, right? ABCS. Some people remember it as ABCD, right? What does A stand for?
Acidosis, sir.
Acidosis. B?
Bleeding.
Bleeding. C?
C is hypocalcemia.
Low calcium. D?
And hypoglycemia.
Hypoglycemia or low dextrose. Right? If the child is not responding to fluids, you need to suspect if this dengue child has got one of these 4 possibilities. First one, A, whether the child has got acidosis. Whether the child has got acidosis. Number 2, check if the child has got some bleeding inside. Gut එකේ bleed වෙනවා වෙන්න පුළුවන්. He might be bleeding somewhere. C, low calcium. If the child is having low calcium, however what you fluid give, he might not recover because the heart is weak, all those problems, right? And the D, dextrose, low glucose. If your energy is not there, you might find it difficult to fight against shock, right? So what are the 4 things that you need to check? A, B, C, D. Acidosis. Now, Fahumida, how do you check the child has got acidosis? What is the test you do?
We might need to check the pH level, so we might need to do ABG or like VBG.
Blood gas. Yes, blood gas, right? You will do a blood gas to see if the child has got acidosis. Bleeding?
We might need to do a coagulation profile, maybe like PT.
You might do coagulation profile. Also, if the child is bleeding, what does he bleed? Red cells will go out. Red cells will go out. Therefore, hematocrit will drop. Hematocrit will drop, right? If the hematocrit is dropping, all of a sudden and child is deteriorating, you consider possibility of bleeding. Was that understood? Then scenario එක දුන්නොත් පුතා, child is deteriorating, hematocrit is dropping. You need to suspect what? Bleeding. You need to suspect bleeding, right? And then how do you check hypocalcemia for?
So calcium might come along with the VBG result as well.
Absolutely. Blood gas itself will show calcium. දැන් ඔහොම එකක් වයිවා එකේ කිව්වම you know that you have got some familiarity to emergency setting, right? Calcium එක blood gas එකෙත් එනවා. Or you can send a separate calcium test to the lab, right? If the calcium is low, you need to give calcium. Then the other one is what? Dextrose. How do you see if the sugar is low?
You can do a random blood sugar or else.
Yes,
it will be
you
more.
do a random blood sugar, or your blood gas will also have that.
Yes.
Blood gas එක ඒකක් තියෙනවා. Right? Blood gas එක ඒකක් තියෙනවා. Right? What is the other thing? Blood gas will also give you an idea about hemoglobin, hematocrit. Right? Blood gas එකේ not only pH. Blood gas එකේ පුතා pH විතරක් නෙවෙයි තියෙන්නේ. As you very correctly told, it will have pH. It will have what? Calcium level එකත් blood gas එකෙන්ම හොයාගන්න පුළුවන්. Right? It will be calculated. And then the bleeding, hematocrit will drop. So you will see the hematocrit and hemoglobin level also in the blood gas report. Fourth one, dextrose, sugar. Right? So all 4 complications of dengue fluid refractory shock can be detected by blood gas itself. Right? Blood gas itself. Blood gas එකක් කරාම ඔක්කොම ඇති. ඔය හොඳටම ඇති. Was that understood? Right. So what is the most important thing? If you have found the child is not responding, right, rather than giving boluses or crazy vela boluses some person should think about in a rational mind and say Fahumida is working in Karapiti hospital. That is what she wants to be, probably. So Karapiti, Fahumida, now see, we have given fluid. Doesn't look like he is getting better. Shall we do a blood gas? That's the teamwork, right? One brainy person has come to the scene. Other people are exhausted with whatever the management. It was a fresh mind. Then he or she will say, okay, we will start. We will do a blood gas. Was that understood? So that is what you do, right? Okay, thank you. Thank you, Fahumida, right? Okay, thank you very much. Right, so if we go back to the note, right? If we go back to the note, then you need to see if the child has got any of the complications. One of the complications, sticker A, B, C, D, right? So what are those complications? A, B, C, D. A is acidosis, right? This is caused by poor tissue perfusion. Poor tissue perfusion, there will be lactic acid formation, right? There will be lactic acid formation. Then exam pH less than 7.25, bicarbonate less than 15, that is metabolic acidosis. Metabolic acidosis in fluid refractory shock in dengue, what do you give? Sodium bicarbonate 1 ml per kilo. Right? Blank ඇත්තේ, you can write, right? You can write 1 ml per kilo sodium bicarbonate. Was that understood? Right. If the child is bleeding, what happens? Hematocrit will suddenly drop. You can write child will deteriorate and hematocrit will drop in this situation, right? Hematocrit will drop, right? And right? You give 5 ml per kilo pack cells. 5 ml per kilo. Pack cells 5 ml per kilo. Do you give platelets? You don't. You don't give platelets. Platelets right? 5 ml per kilo fluids blood right? And then you need to monitor hematocrit again. And do you give fresh frozen plasma? Again, we don't commonly give, right? FFP is routinely given. True, false, okay? That is false, right? Platelets are routinely given, again false, right? Then management of hypocalcemia. Calcium aduna. If the child is having low calcium, they might have seizures, arrhythmias, worsening of clinical status. Then you give calcium gluconate. All right. You see, in this class, I'm going into the depth, right? I have been working as a consultant and a teacher for 15 odd years, and then an examiner to local students, and I have been involved in paper making. So I know how much you need in each point. Mata nephrotic session එකක් නම් අද කරන්න තිබුණේ පුතා. I'm not going to go into that depth. Nephrotic එකට මම ඉච්චර depth එකට යන්නේ නැහැ. Because that is not needed. If you need the depth, come tomorrow. We have what? Advanced pediatrics postgraduate class. Right? ඒකේවා දැන් මෙතන කරලා වැඩක් නැහැ. Right? So I know the depth. That is the amount of depth. But then dengue, I know you need this depth. Right? Dengue is house officers drama. I think house officer මේ ටික ඔක්කොම දැනගන්න ඕනේ. Nephrotic? No. Nephrotic you need to know adequate amount. Right? But I'm not going to talk about very deep knowledge about nephrotic. That should be known by a pediatrician. ඒ නිසා තමයි advanced pediatrics එකේ registrars ලට උගන්වන්නේ. Right? So that's different. So here you need to know everything. Dengue එකක්වත් අමතක කරන්න එපා පුතා. මේ ටියුට් එකේ තියෙන හැම එකක්ම A to Z දැනගන්න ඕනේ. right? That is why I made it like 16 pages or so. So management of hypoglycemia. Hypoglycemia, when the sugar is less than 70 milligrams per deciliter, that is hypoglycemia. So this is, if you go by millimoles වලින් ගත්තම නම් around less than 4 millimoles නම් hypoglycemia, then you give 2 ml per kilo, 10% dextrose bolus. 2 ml per kilo, 10% dextrose bolus, followed by infusion of 5% dextrose or normal saline with 5% dextrose. Was that understood? ඕක තමයි hypoglycemia manage කරන්න. Right? ABCD manage කරන හැටි දැනගන්නත් ඕනේ. Grade 3 shock or compensated shock manage කරන හැටි දැනගන්නත් ඕනේ. Decompensated shock management කරන හැටි දැනගන්න ඕනේ. And then critical phase management you need to know. Are we clear? Right? එකෙන් එකට manage කරන හැටි පොඩ දැනගන්න පුතා. So when you know that, but dengue, right? Dengue, you know, there will be like 25 SBS in the paper. 25 SBS out of 25, at least there will be 2 questions from dengue, right? Directly or indirectly. And then true false, another 25 questions, another 25 true false. මං කියන්නේ ERPM අයට locals lage වෙනස්, locals lata 30 SBA and 20 true false, whatever it is, 10% of the paper will be dengue, right? Then is there a way to go away from dengue? No. Clinicals, again dengue, right? Long case dengue, short case dengue, emergency dengue. So නිකන් superficially මේක දැනගෙන තිබුණොත් ඔත්තන හරි යන ගන්න වෙනවා. Right? MCQ එක ගොඩ දාගත්ත එහෙම මෙහෙම කරලා. හැබැයි YY එකේ ආයෙ නාන්න වෙනවා. So we need to know this very well. A to Z, top to bottom, you need to know about dengue. Right? So that's about dengue management in complicated dengue management. Right? Then when it comes to special populations, right? Infants will have a shorter critical phase. Api leakage එක, we discussed leakage is around 48 hours. But when it comes to infants, it could be short. It could be short. They will leak short and finish short. Right? They are more prone to get low glucose, hyponatremia, right? Hyponatremia is low sodium, low glucose, right? Early use of dextran may be required, right? If the child is otherwise well, if they ask a MCQ, could you continue breast milk? Yeah, yes, you can continue breastfeeding. Hurry. Obese children, right? Obese children, when it comes to obese children management, they are at a higher risk of going into shock and fluid overload, right? If the child is obese, suppose 5-year-old ළමෙක්, right? He should be, say, around 15 kilos na baravendoni. Suppose this child's weight is 30 kilos. 5-year-old, 30 kilos. Right? Dharmikage baravagi. Right? So 5-year-old, 30 kilos. Now are you going to calculate fluids for his 30 kilos because he is obese? No. Right? There is a formula, right? Formula එකක් තියෙනවා, adjusted weight. You need to make sure that you calculate fluids as per adjusted weight and then you give accordingly. Was that understood? Right? So fluid, the weight should be adjusted. Early catheterization may be needed. Right? Early catheterization may be needed. Right? Was that understood so far? Right. Then what are we going to do? Now, this is one of the commonest areas that they might ask questions. Expanded dengue syndrome. Right? Expanded dengue syndrome. Okay. So if we go to the expanded dengue shock management, right? Expanded dengue shock, in addition for them to get normal dengue, right? There will be some other organ involvement. Example, right? And other organs, CNS could be involved. When the CNS is involved, there could be encephalopathic signs, seizures, encephalitis, intracranial bleeding. So these are possible. Cardiovascular, they can have myocarditis, right? Dengue can cause myocarditis, arrhythmias, pericardial effusions, heart failure, right? Heart failure. And hepatic problems, they can get fulminant hepatic failure, right? Dengue wala complications tama මේක පුතා. අපි ඒකට කියනවා expanded dengue syndrome කියලා. Right? This is a very well defined area in our guideline. So we need to know, right? Myocarditis, cardiac arrhythmias, pericardial effusion, hepatic, fulminant hepatic failure. Renal, they can go into acute kidney injury. Respiratory, acute respiratory distress syndrome and pulmonary hemorrhage. Hematological, they can go into coagulopathy, right? This is one of the rare occasions we give FFP in dengue. Otherwise, we don't usually give gastrointestinal severe hepatitis, right? Severe hepatitis, right? And then we need to know what investigations we do. We tend to do full blood count, liver and renal functions, coagulation profile. Chest X-ray, if you are suspecting involvement of the lungs. Blood gas, of course, we do. CSF, if you are suspecting CNS involvement or dengue encephalitis. Organ support, the make organ support. If the child has got CNS involvement like cerebral edema, you might have to elevate the head, control seizures, hypertonic saline. If the child has got cardiac problems, example, arrhythmia, myocarditis, you might have to go for inotropes, right? Inotropes. Renal, we need to monitor serum creatinine, right? And then you might have to go for dialysis, right? Bleeding, right? If the bleeding is very significant, you might go for platelet transfusion. This is not commonly given. If the child is having expanded dengue shock syndrome, you might have to consult an expert, then you decide platelet, otherwise you don't give, right? If the child has got secondary infection, of course, you might have to give antibiotics. But do you give routine antibiotics? We don't. We don't give routine antibiotics in dengue. What are the reasons why a dengue child could die? Dengue lamik marine, right? Marine hetu prolonged and uncorrected shock, right? Prolonged uncorrected shock. Prolonged shock and massive bleeding. Make a MCQ causes of death in dengue, right? Fluid overload and pulmonary edema. Severe organ dysfunction like expanded dengue shock syndrome. Secondary sepsis, right? Then hemophagocytic lymphocytosis, that is too much for you, right? Electrolyte imbalance. Hypocalcemia can cause arrhythmias and then it can cause death, right? But luckily, most of the children will recover. Most of the children will recover. So what are the signs of recovery? When they recover, platelet will start rising. This is the best marker of recovery. Best marker of recovery is platelet rise. And tachycardia will settle. Instead, they will now have bradycardia, right? Whatever the fluids will now start losing as diuresis. Appetite will improve, right? Appetite will improve, right? And there will be a rash. Was that understood? Rash, right? අපි හිතමු ward round එකට යනකොට say when you go for the ward round, right? Say Tarmika is going on a ward round, right? As the house officer, මේ ළමෙක් biscuit එකක් කකා, right? ඇඟ කහ rash එකකුත් එක්ක හැම වෙලේම toilet එකට යනවා නම් චූ කරන්න, that child should be discharged. ගෙදර යන්න ඕනේ ළමෙක් දැන්. මොකද්ද? Child is recovering, right? Child is recovering. Appetite is back, eating and drinking, diuresis, right? When you examine, there is a rash, itchy rash, that is called dengue recovery rash, right? And then there will be good appetite, right? And then monitoring, and then what happens? Usually platelet count will be, when do you think of discharging? Platelet count should be more than 50,000. That is the cutoff, right? Child should be fever free for at least 48 hours, right? Appetite is improving, right? Fluid related complications, ascites, effusions, those are not there, right? Then you think of discharging the child, right? Baba discharge කරන්න, right? Was that understood? Right. Then couple of things about dengue vaccine, right? Dengue vaccine. Right, couple of vaccines are there. This could be tested. This was tested in the past, right? Couple of vaccines are there. Dengue vaccine is one of the commonest, right? So it is only recommended for seropositive individuals, like previous dengue hadich අයට තමයි, right? Seropositive individuals ලට තමයි මේක දෙන්නේ, right? And then there is another one called Qdenga. So there, it's a live vaccine, right? Live vaccine. And then efficacy is broad, and especially against hospitalization adu karanna puluwan when you give this vaccine, right? And then there is NIH TB003 vaccine and TB005 vaccine. And this is like the trials are ongoing, right? Trials are ongoing, right? So WHO recommendation is usually give this dengue vaccine for seropositive children, right? And then so none of these vaccines are protective against all four serotypes. All four serotypes are against karanda beha, and some of these vaccines are in ongoing trials, right? That is a part of prevention of dengue. But the other thing that we need to know, dengue prevention karanda thawa kramayak mokadda? Notification. Notification. We can write a small topic. Dengue notification. How do you notify dengue? Dengue notification, you need to inform the PHI and MOH. That PHI and MOH, there is a notification form. Notification form kiyala ward ekේ pediatrics ward එකේ තියෙනවා. That form should be filled by the house officer, right? That form should be filled by the house officer, and then somebody should be able to send that to the MOH, right? Send that to the MOH. So that's what you do when it comes to dengue notification, all right? Are we currently using vaccine in Sri Lanka? Not routinely, right? But trials are ongoing, right? Trials are ongoing, even at LRH, right? So that's it, right? Then we will, yeah, so that's about it. We will now discuss a couple of questions. Before that, we need to make a dengue summary, right? Dengue summary. Summary එක හැදුවා. ඊට පස්සේ ඉක්මනට questions වලට යන්න. All right. So what do you have to write in this summary, right? First, please write. අපි දැන් මේ පිටු 16 one page එකට summarize කරන්න යන්නේ. Right? We are going to summarize that to one page. Right. So first thing, please write dengue history, right? History. You can write මොනවද ලියන්න ඕනේ history එකේ කැලේ ටික ලියන්න. Fever, right? Arthralgia, myalgia, right? Retroorbital pain, abdominal pain, right? This is the chart that we are filling. Yes. Eshani, can you see that I'm sharing a short note thing? Yes. So history, arthralgia, myalgia, retroorbital pain, abdominal pain, nausea, vomiting. Right. Then examination, what do you have to examine for? Fever, ill-looking or well-looking. As Doji very correctly told, blood pressure, sorry, body weight, right? Body weight, right? There could be a rash and level of dehydration. හරි ඊළඟට මොකද බලන්න examine කරන්න ඕනේ දේවල්? Examine for features of leakage. Leakage. මොනවද leakage එකේ ලියන්න ඕනේම? Pleural effusions, ascites, sometimes pericardial effusions, right? Those. ඊළඟට examination point එක මොකද්ද? Evidence of shock. Evidence of shock බලන්න. Blood pressure, pulse rate, pulse pressure, and capillary refilling time. Capillary refilling time. හරි. ඊළඟට යන්නේ මොනවද? Investigations. මොනවද කරන්නේ? After 2 days, full blood count. What do you expect? Low platelets, low WBC. There may be a rise in hematocrit. Then within first 5 days, you also can do NS1 antigen. After 5 days, antibody, dengue antibody, right? ඊළඟට evidence of leakage බලන්න කරන investigations, PCV, packed cell volume will be high. Platelet less than 100,000 in general, right? Platelet less than 100,000, right? How මොනවද වෙන්නේ? There will be fluids in ultrasound scan, right? Fluids in the chest and abdomen. If you do blood investigations, low albumin, right? low cholesterol. Right. Organ involvement එක බලන්න ඕන නම් what are the investigations that you do? Liver function test, renal function test, right? Liver function test, renal function test, right? And then coagulation profile, PTIN now. ECG, cardiac problems බලන්න, right? ECG, right? And EEG, MRI if you are suspecting encephalopathy. Right. Now the management, short and sweet management. Dengue fever only. What is the management? Fluid maintenance over 24 hours. Oral or IV. Fluids maintenance over 24 hours. Oral or IV. Right. Then full blood count twice a day. Right. You might do PCV, pack cell volume also twice a day. Right. Paracetamol 15 milligrams per kilo. Right. Dengue critical phase management, critical phase. Right. These are the types of charts that we are summarizing the whole syllabus in pediatrics at a glance course. එහෙම කරලා තමයි 22 hours වලින් syllabus එක cover කරන්නේ. And then we do questions, right? Right. Dengue critical phase, right? Before I make any more confusions regarding this pediatrics at a glance, if you have already registered to SBA master course, this course will be free for you. Our previous students, Puda, you don't have to pay any more, right? SBA master course එකේම මම ඒක තවත් develop කරලා තව කැලි එකතු කරලා new videos දාලා තමයි මේක හදලා තියෙන්නේ, right? If you have already registered to that, you don't have to pay any more for this course. But for a new one, this is the course, right? So dengue critical phase management, ලියමු මොකක්ද පුතා? Fluid quota, that is maintenance plus 5% deficit over 48 hours, right? Maintenance plus 5% deficit over 48 hours, right? Then monitor blood pressure, pulse rate, respiratory rate, urine output hourly, right? Our previous dengue fever, how frequent? You might monitor like 4 to 6 hourly, right? 4 to 6 hourly. Dengue critical phase hourly, right? And then you need to monitor pack cell volume 6 hourly. Pack cell volume 6 hourly. That is the management of critical phase. Compensated dengue shock. What is the first step? Normal saline, 10 ml per kg over 1 hour. Second step, normal saline, 10 ml per kg over 1 hour. All right. Third step, if no response, dextran 40, 10 ml per kg over 1 hour. Right. Dextran 40, 10 ml per kg over 1 hour. Hari පුතා ඊළඟ එක මොකද්ද? Decompensated shock. What is the management? Normal saline 20 ml per kg, 20 ml per kg as a rapid bolus. 20 ml per kg as a rapid bolus. All right. If no response, go for dextran 40 straight away. Dextran 40. Right. ඊළඟට අහන very important scenario එක මොකද්ද? Right? If the child is bleeding, right? So how do you recognize? පුතා එක ලියාගන්න. රන් අකුරෙන් ලියාගන්න, තරු දාන්න, වල්ගා තරුවක් දාන්න, right? So what is the important thing? If the child is deteriorating and hematocrit is dropping. Hematocrit is dropping and child is deteriorating. Hematocrit is dropping and child is deteriorating. What do? You go for blood transfusion. This means that the child is bleeding. So you go for blood transfusion. Right?
Excuse me, sir.
Yeah.
Sir, in the case of a bleeding child, the PCV is expected to drop. But
Yeah.
in the case the child is simultaneously bleeding as well as leaking, the PC will be constant. So what is the most sensitive marker in that case to identify bleeding?
It's very difficult. If the bleeding is there, anyway, hemoglobin will drop, right? Hemoglobin will drop, or you will see the evidence of bleeding, like there will be melena, right? There will be some obvious bleeding, right? So it's not difficult to differentiate whether it is bleeding or leaking. Your scenario, Angelo, is extremely rare, right? Usually, when they bleed, bleeding is out of proportionate to leakage, right? Therefore, usually they will have drop in hematocrit, right?
Understood, sir. Thank you.
Right. Okay. So that's dengue, right? So we discussed case scenarios, history taking, everything, right? Now we'll go to questions and see how to approach to questions.
Excuse
Right.
me, sir.
Yeah.
So if we're managing a patient for compensated shock with the fluid boluses, but then in our reassessment, the patient goes into decompensated shock, do we start the algorithm again from the beginning with decompensated shock with a new fluid quota, or do we go to colloids?
We usually, if the child is, suppose you have given 10 ml per kg and he went into decompensated shock, then we usually go for 20 ml per kg bolus rather than giving the remaining 10 ml.
Thank you, sir.
Right? Okay. Because decompensated meaning the organs are highly hypoxic, acidotic. And in that case, you need to go for a fresh 20 ml per kg bolus anyway. Right? So in this scenario, usually your consultant will come and then the scenario will be more of a consultant-driven management. Right?
Thank you, sir.
Right. Yes, welcome. Right. Okay. 10-year-old child with a body weight of 30 kilos presented with fever for 3 days, heart rate 110, blood pressure 100/60, capillary refilling time less than 2 seconds, PCV 44. What is the fluid management? Right. Now, when you look at this scenario, you see heart rate is slightly high. Blood pressure is normal. 100/60 is normal. Even the pulse pressure is normal, right? Pulse pressure is normal. PCV is 44. So that is high, isn't it? I was discussing more than 42 is leaking. So this child is leaking. And then you see reduced air entry to the right lung. Right lung eකට air entry තඩුයි. So what is this? Child is leaking. Is he in shock? No, not in shock because the blood pressure is normal, right? Not in shock. So what is the management? The management should be critical phase fluid management. Critical phase fluid management, isn't it? Does everyone understand that this child is in critical phase? Yes, neither. Reduced air entry කිව්වම critical phase නේ. Right? Hematocrit එකත් වැඩි. දැන් ඊළඟට හිතන්න ඕනේ MCQ එකේ has he gone into shock? Has he gone into shock? No, he has not gone into shock because the blood pressure is normal, pulse pressure is also normal, right? Now when you do pediatrics paper, you go to pediatric mode. හරිද? ඔළුවයි හදවතයි හැම එකෙන්ම ළමයි දිහා බලන්න. Medicine paper එකේ 100/60 දැක්කොත් probably he is in shock. ඒ මේ ළමයාගේ තාත්තා, right? For this child, this blood pressure is normal. Right? Remember, children have different blood pressures. Their normal blood pressures are different. Right? So this child's blood pressure is normal. He is still leaking. So what is the management? This is critical phase. අර බුත්සරණි කිව්වා වගේ fluid quota එක තමයි දෙන්න ඕන. When you know fluid quota, it should be given over 48 hours. Right? Over 48 hours. Even if you do not look at any other option, this should be correct. Because this is the only option where you see 48 hours thing. Was that understood? Right. Anyway, how do you calculate the amount of fluid needed? Right? Amount of fluid needed calculate කරන්නේ කොහොමද? Maintenance. What is the maintenance for a 30 kilo child? First 10 kilos, 100 ml per kilo, that will be 1000. Next 10 kilos, 50 ml per kilo, that will be 500. How many more kilos left? ඔක්කොම 30 නේ 10 more නේද? That 10 kilos 20 ml per kilo, that will be 200. So what is the maintenance? 1000 plus 500 plus 200 is 1700 is the maintenance. 1700 is the maintenance. ඊට පස්සේ මොකද වෙන්නේ? We also have to give what? 5% deficit. 5% deficit. So 30 kilo nang 10% is 3 kilos. 5% is 1.5 kilos. 1.5 kilos is 1500 milliliters. 1500 milliliters. Right. And then that 1500 plus 1700 is 3200 or 3.2 liters. 3.2 liters should be given over 48 hours. Was that understood? This answer is wrong. Normal saline 10 ml per kg bolus is given in compensated shock. His pulse pressure is normal, so that can't be the answer. 20 ml per kg bolus is only given in decompensated shock. His blood pressure is normal, so he is not decompensated. Over 24-hour fluids are not given in case of critical phase. That should be over 48 hours. Oral fluids and monitor hourly is not recommended because this child has gone into leakage. IV fluids are needed, right? So when you do SBS, you need to know what the correct answer is. Equally, we need to know why other answers are wrong, right? Other answers are wrong. You know 100% my answer is correct. Right. Okay, next question. 8-year-old child currently admitted to ICU with 5-day history of fever. His blood pressure is 80 by 50. Heart rate is high. Capillary refilling time 4 seconds. PCV has changed from 46 to 49. Right? He has already received normal saline 30 ml per kg in total. Right? pH 7.29. Bicarbonate 22. RBS 4.2. What is the next step of management? Then next step of management එකට යන්න කලින්, right? What is this child having කියලා හිතන්න. What is this child having? Right? Is he in shock? Yes or not? Yes. See, the blood pressure is very low. Even the systolic blood pressure is very low. Capillary refilling time is 4 seconds, mean the peripheries should be ice cold. Right? So he is in shock. PCV is still going up. PCV is increasing. Then this can't be bleeding. Ne? This can't be bleeding. PCV වැඩි වෙනවනේ. That means he continues to leak. He continues to leak. Somebody has already given normal saline. Right? Somebody has already given normal saline. He is in the ICU. Right? Now in this occasion, what should we do? Are you going to give another normal saline? No, that will be too much, isn't it? Crystalloid, ඔච්චර දෙන්නේ නැහැ. Right? Urgent blood transfusion. Do you go for blood transfusion? No, this child is not bleeding. Why? Hematocrit is not dropping. Are we going to give bicarbonate? That is where guideline matters. You give bicarbonate when the pH is less than 7.25. 7.25, and bicarbonate should be less than 15 or so, right? Which is not the case here. So you don't give bicarbonate. Then hetastarch is a colloid. Dextran 40 is also a colloid. You can give either of those. That normal saline දුන්නට පස්සේ, if the child is not responding, you go for colloid. That is as per guideline, isn't it? Out of 2, in Sri Lanka, we consider Dextran 40 as better. Right? Single best answer paper එකක් නේ. Right? Single best answer paper for Sri Lankan doctors. Right? එහෙමනම් you go for Dextran 40. Right? You go for Dextran 40. Right. Now this is most argued question. Right? 12-year-old child presented with fever for 4 days. Lungs, bilateral equal air entry, abdomen, no free fluids, heart rate 130, low volume pulse, blood pressure 80/40, capillary filling time 4 seconds, hemoglobin 12, platelet 130, WBC 3500, CRP 6. What is the next step of management? We'll forget about next step of management. Next step of management, can someone tell me what this child is having? මේ ළමයාට මොකද වෙලා තියෙන්නේ කියලා හිතමු. ඕක ඇහුවනම් මම instead of asking next step of management, if I have asked what is the likely diagnosis? What is the likely diagnosis? Oh, what are the possibilities rather? Manage කරන්න කලින් දැනගන්න එපා මේ ළමයාට මොකද වෙලා තියෙන්නේ කියලා. Anyone?
The patient is in shock, sir.
Patient
But
in shock. Yeah, we'll stop at that point for the time being. Patient is in shock. Why? Blood pressure is very low here. See, blood pressure is very low, right? Capillary refilling time 4 seconds. So he is in shock. No two doubts, he is in shock. Yes, Angelo, go ahead. Is that Angelo?
So there's visible
Somebody was. Yeah, yeah.
There's hypovolemia, but there isn't any hemorrhage because hemoglobin is normal.
Yeah, so this child is in shock, but doesn't show features of even leakage, isn't it? Leakage feature එකක්වත් නැහැ. See, bilateral air entry is normal. So he is not leaking. And when you are leaking, you expect hematocrit to go up, isn't it? Hematocrit should be high. Here the hematocrit is even normal, 36. Normal hematocrit. No signs of leakage. Still in shock. Isn't it? But is this dengue? Yes. Clearly says that the child's platelet count is what is this? 130, right? Say PC. So say if I also say NS1 positive, you know that it is dengue, right? Dengue, right? No leakage, right? But in shock. That is where we need to know about what? Expanded dengue syndrome, right? One of the ways a dengue child could present in shock, in addition to typical, very well-known dengue shock, is dengue cardiogenic shock. Dengue cardiogenic shock. When this happens, child usually goes into myocarditis, right? Myocarditis, right? Abdomen, there will be possible tender hepatomegaly, right? There could be tender hepatomegaly in the abdomen. That is to show that child has gone into heart failure, right? අපේ අර WhatsApp question එකේ මම දැම්මා tender hepatomegaly එකකුත් තියෙනවා කියලා, right? So when you have tender hepatomegaly, that is suggestive of dengue hemorrhagic fever itself can cause tender hepatomegaly. Also, it could be a sign of heart failure, right? Children with dengue virus can directly infect the myocardium. Then you get what? Myocarditis. When you get myocarditis, older people will come with chest pain. Adults or children might be completely asymptomatic, right? They could be asymptomatic, right? Then, when you have myocarditis, can children have myocarditis without going into leakage? Yes. If you read the guideline, you will say organ involvement could occur in the absence of leakage or shock, right? Leakage, leak වෙන්නේ නැහැ. Leak වෙන්නේ නැතුව myocarditis යන්න පුළුවන්, right? When you go into myocarditis, myocardium is failing, so the child can't pump enough blood, circulation will go into shock, right? Circulatory shock. Now, when you go into circulatory shock, it will be cardiogenic shock. When you have this cardiogenic shock, right? As a house officer, Puta, we need to understand that every child presenting with low blood pressure in dengue is not dengue hemorrhagic shock. This could be something else. Especially in this scenario, you see the child's hematocrit is normal. Air entry is normal, right? Then මෙහෙම වුණාම, right? If you are the house officer, Eshani house officer නම් Eshaniට පුළුවන් වෙන්න ඕනේ. right? Management, amataka karanna puda. You have to tell your registrar or consultant now see, he is not having features of leakage. Even hematocrit is normal. However, he is in shock. Anne alarm එක දෙන්න ඕනේ. Right? ඒක කියන්න ඕනේ. ඔයා කියන්න ඕනේ මෙයා leak වෙන්නේ නැහැ. ඒත් shock එකේ ඉන්නේ. Right? Then somebody should understand that this could be cardiogenic shock. Could that happen in dengue? Yes, that can happen in dengue, especially if they have gone into myocarditis. Can myocarditis occur without leaking? Yes, it can. Now, when they go into myocarditis, it will be cardiogenic shock. The importance of understanding or detecting this is Pudawai. On top of cardiogenic shock, if you give a fluid bolus, as usual, child might die of fluid overload. Right? The heart is already failing. On top of failing heart, right? If you give more and more fluids, he's going to die. Right? Of course, this child will need some amount of fluid. That is not the point. But we need to understand that this child is a different scenario. Right? He's a different scenario. So what do you have to do? Normal saline over 1 hour. This is the management of the compensated dengue shock, like plain and simple dengue shock. This is not the case here. He's not even leaking. Right? This can be considered if it was typical dengue shock. This doesn't look like typical dengue shock. You might give this, but child might die. Child might die. Fluid bolus එක දුන්න ගමන් බබා හුස්ම ගන්න අමාරු වුණා මැරුණා. That happens when you give a lot of fluids in cardiogenic shock. Right? Immediate blood transfusion, he doesn't need blood transfusion. Right? Hemoglobin is normal. See, hematocrit is normal. Right? It doesn't show any features of bleeding. Adrenaline infusion. Adrenaline is a vasoconstrictor, right? That might be, and then it will improve the heart with inotropic chronotropic effect. That might be useful. That might be useful, right? And then get an urgent ECG. Would that be useful? Yes. Urgent ECG is urgent. You do it very urgently. Bedside, right? Very urgently. අපිට facilities තියෙනවා නම් අපි ECG කර කර ඉන්නෙත් නැතුව you do a ultrasound chest, right? Fast scan එකක් chest එක ultrasound chest එකක් කරලා බලන්න පුළුවන් ejection fraction එක කීයද කියලා. Right? I'm talking about the best management. I'm not talking about the emotional management. Shock එකේ නම් ඉන්න ඔච්චර එක හිතේ ඉන්න නැතුව bolus එකක් දෙන්න. You don't do that. Right? You don't do that. This child might need a bolus, but how fast are you going to give that? How much are you going to give that is usually decided by the cardiac status. I am not telling that this child doesn't need fluid. He needs fluids. Definitely he needs fluid. Right? How much of fluid to be given, how fast should we give that is usually decided by knowing about the cardiac status better. Right? Cardiac status better. For you to do this, it might take less than 1 minute. That 1 minute is not going to kill the child. Right? Rather than panicking and jumping and giving a 20 ml per kg fluid bolus and making patient to go into pulmonary edema and hemorrhage, and that can cause death. Right? Dunda fluid එක අපෝ එළියට ගන්න බැහැනේ. Right? You need to understand when the things are atypical, think one more time. But remember, emergencies doesn't mean that you doctor also has to panic. That make emergency එකක් ඇවිල්ලා තියෙනවා. අර නිකන් රංගපාන්න මොනවා හරි කරන්න නෙවෙයි ඕනේ. Right? මේක ඇඩ්‍රිනලින් උත් දෙනවා, මේක දෙනවා, ICU ඩක් කතා කරනවා, ඉන්ටියුබේට් උත් කරනවා, කැතීටර්ස් උත් දානවා, නිකන් මාර ඩ්‍රාමා එකක්. That is to make the gallery entertained. Right? එතකොට අර ගමේ මිනිස්සු කියනවා මේ ડોක්ටර් කරන්න තියෙන හැමදේම කරන්න. IT ඇඳගෙන ආවේ, දුවගෙන ආවා, ඇඳ උඩට නැගලා ජම්ප් කරලා මේ මෙහෙම කරා. ඒ කරන එකක්වත් තේරුමක් නැහැ. Right? So here we need to understand that this is an atypical presentation of dengue. Right? It's an atypical presentation of dengue. This is not leakage. This is not plain and simple grade 3 shock. This is not plain and simple profound shock. There is something else in this. This is what you need to understand. Right? Once you have understood that, right, rest of it is to seniors. Usually what we do is we tend to do a cardiac scan or ECG. If ECG shows like ST depressions, like generalized ST depression, myocarditis, right? Then you give fluids in a controlled manner while giving inotropes from the other drip. එක drip එකකින් inotrope යනකොට අනිත් drip එකෙන් fluid දෙනවා in a controlled fashion, right? We don't want to kill this child by making him to go into more and more severe shock. Same time, we don't want to overload this child either, right? That's the fine-tuning balance you need to make sure that this child is not going to die. Otherwise, either this child is going to die for non-treated or untreated shock, or he is going to die of fluid overload causing heart failure worse. Right? So, you tend to call ICU, right? Consultants, pediatrician ICU, anesthetist pediatric intensivist the regular hurry slow bolus 10 ml per kg, bolus 20 inotrope patanganda, right? Tava cardiac status monitor karanda. That's the kind of situation. Right? This is complicated, expanded dengue manifestation. This is what you do. To be honest, it's rare for a question like this to come for ERPMO final MBBS question. But why did I want to put this? To give an idea about the complexity of dengue at some times could be. Right? Yes. Are there any questions about this question? So the answer should be get an urgent ECG. Right? This should be the most important thing to do. This should not take a lot of time. But anit mukakkarat, that might be like doing things in blind. Yes, you can ask for that.
So usually in cardiogenic shock, we first tend to give normal saline, right? In all the cardiogenic shock. So here like that, due to dengue expanded syndrome, due to cardiogenic shock, can't we first try the normal saline and then get the ECG? Because
we can give. Now, ideally, what you do is we tend to give 10 ml. I understood your point, Putha. It's very valid point. You might give 10 ml per kg bolus. අපි usually මේ වගේ වෙලාවට inotrope support එකක් එක්ක 10 ml per kg bolus එකක් දෙනවා. But that bolus, if you are thinking about cardiogenic shock, that bolus should be given like fairly rapidly, 10 ml per kg. But here, there is no such option. Here it says normal saline 10 ml per kg over 1 hour. You don't do that if you are worried about cardiogenic shock. Cardiogenic shock, now you give it fast, but 10 ml per kg. Yeah, give it fast.
Understood, sir. Thank you.
Yeah. Yes. And the other thing, normal saline 20 ml per kg bolus is not given in suspected cardiogenic shock anyway. Right? We can give normal saline 10 ml per kg as a bolus, not over 1 hour. Over 1 hour, then dengue. Right? Here you don't have to give it over 1 hour because we are not suspecting leakage. Leaking, we give it slowly, otherwise it will leak fast as well. Then leak. Yeah. So
Thank
this
you,
is a complex question. Yeah, I just wanted to do this to give some idea about lateral thinking. Yes. Are there any more questions? Right. Next question. Next question. 4 months old child admitted with a history of fever and feeding for 2 days. Dengue was suspected. What is the best investigation to confirm? Then 2 days, 2 days fever and best investigation should be NS1, isn't it? Right? Fairly straightforward. Right? Fairly straightforward. These are all past exam questions. Right? Make past exam, this is a model question. Right? In our SBA course, some questions are model questions and they are slightly difficult. This is to make sure that your real exam paper is easy. Right? Real exam paper is easy. Right. Yes. Especially this should be the case with especially locals and New syllabus ERPM students, remember, pass mark is 50 and you only have 2 hours to complete the paper. 2 hours, 2.5 maybe, 2 hours, right? Locals start කොහොමත් ඔහොම තමයි තිබුණේ. ඉස්සරත් 40 if ඉස්සරලා 50% තිබුණේ pass mark එක ඒගොල්ලෝ කොහොමත් 2 hours තමයි තියෙන්නේ. Right? So remember, for you to overcome this challenge, you need to do more and more questions, true false, right? Lot of questions කරලා දැක්ක ගමන් මතක් වෙන්න ඕනේ. හිත ඉන්න ගියොත් ටය දෙක නිකම්ම යයි. Right? Okay, so that's it. 5-year-old child, dengue leakage, right? Dengue leakage, blood pressure is 100/70, urine output 0.8, right? 0.8. Currently, he is on 3 ml per kg fluid rate. He has some ascites. Ascites is not progressive over 4 hours. Ascites එක එහෙමම තියෙනවා. Right? Urine output එක 0.8 is good නේ. හොඳ urine output එකකුත් තියෙනවා. Blood pressure normal නේ. No pulse pressure එකත් not less than 20. Heart rate එකත් හොඳයි. Right? Currently 3 ml per kg over 1 hour fluid rate එකක යනවා. Right? එහෙනම් දැන් මොකද කරන්නේ? Nurse කෙනෙක් කියනවා ડોක්ටර් අර 3 ml per kg fluid යන ලෙඩා එයාගේ urine output එක 0.8 ගිය පැයට blood pressure එක 100/70 ascites එක අර විදිහටම තියෙනවා කියලා තමයි හිතෙන්නේ. So what do you do? What do you do? Yes, he is doing well, isn't he? Right? He is doing well. So continue same fluid rate. I would do that. Increase fluids? No. If the urine output was low, you might have considered this. Decrease fluid rate? You don't have to. The urine output is ideal, right? Normal rate again. Furosemide then don't either? No, he doesn't show any features of fluid overload. Urgent ultrasound abdomen? Why? What for? Right? What are you going to look? No. Which of following is the most reliable sign to indicate the child in dengue fever going into critical phase? Dengue ළමෙක් critical leakage එකට යනවා කියන්න most reliable sign එක මොකක්ද? Platelet count නම් 1000 නේ cross වෙන්න ඕනේ. 1000. Right? Capillary refilling time less than 2 seconds is normal. Right? Gum bleeding is not going to say anything. Gum bleeding could occur without going into shock or leakage. Sudden development of itchy rash means the child has gone into recovery. Right? What tells us that the child is going into critical phase? PCV rise more than 20% from the baseline, isn't it? Yeah, එතකොට අපි කියන්නේ 3-year-old child admitted with dengue hemorrhagic fever, critical phase. Which of following in investigation best assesses the adequacy of fluid? දැන් අපි මේ දෙන fluid ඇති කියලා හිතන්න best mark එක මොකක්ද? It's the urine output. Right? Urine output එක හොඳයි නම් අපි හිතනවා අපි දෙන fluid ප්‍රමාණය ඇති කියලා. Right? 5-year-old child presented with fever for 4 days, blood pressure 110/95. අර ගීත් මිට කිව්ව value එකක්ම මේකනේ. 110/95. Hematocrit 52%, platelet 22,000. He has already had 2 boluses of normal saline. Right? Normal saline, 2 boluses. Yeah. In spite of resuscitation, he started deteriorating. Hematocrit 38. Urine output low. දැන් කියන්න බලන්න මේකට උත්තරේ පුතා. හරි ලේසි. Anyone?
Should be blood transfusion.
Blood transfusion.
Yes, you see, child is deteriorating. Hematocrit is dropping. You see, 52 තිබ්බ 38 වෙලා. Hematocrit is dropping and child deteriorating, fluid refractory shock. As Fahumida was telling, you need to think about A, B, C, D. He must be bleeding, isn't it? Bleed වෙන හින්දා තමයි hematocrit drop වෙන්නේ. Right? Hematocrit is dropping and child deteriorating, not responding to the fluids. You have to think about bleeding. So you need what? Blood transfusion. Blood transfusion. Right? Okay. The එක SBA එකක්, එක true false එකක් can decide the life. pass වෙනවද fail වෙනවද? distinction ද නැද්ද? first class ද second class ද? right? locals ලට. right? university එකට යන්න හරි lecturer කෙනෙක් වෙන්න හරි ඒගොල්ලෝ අහන පළවෙනි එක මොකද්ද? do you have a second class? do you have a first class? right? ඊට පස්සේ exam එක pass වෙන්න of course pass වුණේ නැත්නම් තව මාස 6ක් දඟලන්න වෙනවා. මාස 6ක loss එක කියා නිම කළ නොහැක. right? so you need to know this very well. right? which of following is the best marker of dengue recovery? dengue recovery. right? recover වෙනවා කියන්න best marker එක මොකද්ද? he is recovering, so you might consider sending him home. What is that? Polyuria, itching, increased appetite, rising WBC, rising platelets. Anyone?
Rising platelets.
Absolutely. Rising platelet. This is the best marker. Everything else could occur in recovery, but they are not the best. Right? මට පොඩි එකක් කිව්වොත් පුතා rising WBC ගැන WBC rise will be the earliest hematological feature of recovery. Earliest hematological feature of recovery ඕක තමයි. But best එක rising WBC. Right? Rising WBC. 10-year-old boy is brought to emergency department with high-grade fever for 4 days, persistent vomiting, and abdominal pain. On examination, he is lethargic and has cold extremities, delayed capillary refilling time, weak pulse, blood pressure 70/30, hematocrit 50, platelet 40,000. Best next step. Fairly easy, right? High-grade fever for 4 days. Right, third day, fourth day, tama leak වෙන්නේ, right? Delayed capillary refilling time, weak peripheral pulse, blood pressure is very low, hematocrit is very high, platelet count is 40,000. Where does he lie in dengue ladder? Is it dengue fever, critical phase only, compensated shock or decompensated shock?
Decompensated shock.
Compensated or decompensated? It is likely the child has gone into where? Decompensated shock. Right? Compensated now, systolic blood pressure will be normal. Diastolic will go up with narrow pulse pressure. Here, even the systolic blood pressure is low. Even the systolic blood pressure is low. Right? කොහොමද අපි normal blood pressure බලන්නේ පුතා? 80 plus age into 2. Right? 80 plus age into 2. දැන් මෙයාගේ age එක 10 නේ. Right? 10 into 2 කියන්නේ 20. Right? So 20 plus 80 is 100. His systolic blood pressure should be at least 100. Here it is 70. Right? So he is in profound shock. Right? So if he is in profound shock, the management should be what? Normal saline, 20 ml per kg, rapid bolus.
Excuse me, sir.
Yeah.
In acidosis, bleeding, and calcium and sugar, if more than one parameter is abnormal, which one do we correct first?
You need to correct everything at the same time, like as early as possible. Say, practically say, if the child he's bleeding, he is hypoglycemic, right? His calcium is low. So all these are there now, right? What is the earliest thing that you can correct? Sugar. Sugar එක ඒ වෙලාවෙම sugar bolus එකක් දෙන්න පුළුවන්. Right? Bicarbonate also you can give fairly quickly. Blood transfusion, it will take time because you have to get the blood down from the blood bank and then it might take some time.
So when they are asking question, we have to consider the sugar first.
Yes.
Like let's say that there are more than one parameter.
Yes. It's extremely unlikely that they will give more than one parameter for you to correct at the same time. But if that is given, yes, sugar correction should be the earliest and practical priority.
Thank you, sir.
Right. Okay. Yes. False. Yes. Any more questions?
Sir, in question number 8, because like they're saying 2 boluses of IV normal saline is given, so can't we consider a bolus dextran 40 before going to blood transfusion?
Good question. Good question. I'm sorry I could not explain that bit. So dextran 40, right? As per guideline, say decompensated shock nang, you go for crystalloid, colloid, normal saline, dextran 40. But here, this is not ongoing leaking, right? Ongoing leaking, you give saline, still hematocrit is high. You give another bolus of saline, still hematocrit is high. But here, what has happened? Hematocrit has dropped, right? Hematocrit has dropped. So even if you give dextran 40, child is not going to improve, because the reason for his low parameters is not that he continues to leak, but he is now bleeding. Right now he is bleeding. Just because guideline says after 2 boluses of normal saline, you should go for dextran. No. If you have clear evidence of bleeding, you go for blood transfusion. Right? You go for blood transfusion. That is why dextran 40 is wrong. But if you got the same question, and if I told hematocrit has gone from 52 to 56%, then you know that child is still leaking in spite of 2 boluses of normal saline, then you go for dextran. Right? Then you go for dextran. Here you need to think, am I going to give dextran because the guideline says so after 2 boluses, but is this different because he is bleeding? Then you have to think it little, and then more practical, more rational, then you should go for blood transfusion.
Okay, sir. Understood. Thank you.
Very good. Thank you very much for asking that question. I could not explain this bit. Yeah, okay for that.
Excuse me, sir.
Hmm.
Sir, regarding question 10,
Hmm.
so he has cold extremities, delayed capillary refill, and blood pressure is recordable, and
Yeah.
the peripheral pulse is weak, sir. So
yeah,
why we consider this decompensated rather than compensated in this case, sir?
yeah, Uda, for you to say that it is decompensated, it doesn't necessarily have to be unrecordable blood pressure, right? Decompensated blood pressure, decompensated shock could present with very low blood pressure but recordable, right? How do you differentiate? Decompensated shock, even the systolic blood pressure is low. Even the systolic blood pressure is low. Compensated shock, usually systolic blood pressure is normal, but pulse pressure is narrow. Okay, here, of course, it is recordable, but it is very low, very low. You need to go think this as decompensated shock.
Thank you very much.
Okay. Right. Okay. There was one question regarding clinical sessions. Clinical sessions, we will have a special clinical session for students who are coming for summer break, and for local students who are preparing for their exams, and KDU students. I will let you know about the date soon, right? Date soon. Before that, it's a good idea to complete the Viva course through Smartpedia. Viva course එක complete කරලා CVS respiratory ඒවා examine කරන්න හැටි දැනගෙන ආවම, then the session will be very useful for you, right? Very useful for you, especially if you are not doing exam this time. Exam stress එකක් නැහැනේ. මේ හෙට අනිත් exam නැත්තම්, then this is the best time to do go through clinical course leisurely, and then prepare for the Viva, and then get ready for clinical sessions. Right. Now there are around 20 questions of true false, right? Please go through them. At least I will try to send the answers. If not, SBA most recent past paper I will discuss. But I might not get a chance to discuss this in this session because I have to go to hospital, right? Basically, right? So I might have to stop the session now. Hope it was beneficial, useful. I tried to make it as interactive as possible for you to get the real taste of dengue. And then when we did, that more complex true false SBA questions. So for you must have got very good understanding. Please go through true false questions. Around 20 questions are there. We'll discuss these on a different day. All right. So thank you very much for joining, and have a nice day. you.